So we are planning robotic donor nephrectomy for the donor and the robotic live renal allograft recipient surgery for the recipient. So this is the first case, the donor of which is being broadcasted from OT12. And the second case, so for the second case, we have a 48-year-old female who's donating one of her kidneys to her husband who's 56. It's an ABO incompatible transplant. The donor has a blood group of B positive and the recipient has an O positive blood group. The donor is 48 as I mentioned earlier, and she has a prior history of lap cholecystectomy 2 years back along with lap hysterectomy with right ovarian cystectomy almost 8 months back. On the DTPA, she has a GFR of 43.2 on the left side and 44.7 on the right side. The CT is showing bilateral single renal arteries and single renal veins. The recipient is a 56-year-old male with a BMI of 22.36. He is a diabetic and hypertensive and has a prior history of PCNL in 2004 on the left side. He was initiated on dialysis 8 months ago via right-sided AV fistula and is undergoing dialysis thrice weekly. The flow cytometry and cross-match were both negative. He underwent the desensitization protocol and received rituximab 200 mg, sorry for the typo, 2 weeks prior to the surgery. His titers 48 hours prior to surgery was 1:32 IgG and 1:8 IgM. And he was started on dual immunosuppression of tacrolimus and mycophenolate 48 hours prior to surgery. The post-PEX titers in the morning was 1:1 IgG, and he received basiliximab 20 mg on OT table along with solumedrol 500 mg. So that is the case that we are broadcasting from OT8. The donor is undergoing a left laparoscopic transperitoneal donor nephrectomy, and the recipient is planned for open transplant. So for this session, I'd like to call upon Dr. M.S. Jha, Dr. Priyadarshi Ranjan, and Dr. Rajiv Sharma to please chair the session, please.
दीपक इधर हेल्प चाहिए.
So do we know who's doing the nephrectomy in 8 and 12?
So the laparoscopic nephrectomy is currently Dr. Pragnesh is scrubbed, and in OT12 for the robotic, Dr. Samit is scrubbed currently.
Thank you.
यार ये बाउल का कैसे करेंगे दोस्त?
Dr. Samit, can you hear us?
Sir, good morning, very good morning to all of you, and welcome
morning.
for the second day, or rather
Thank you.
third. Can you hear me, sir?
Yes, yes, we can hear you.
Yeah.
Nice and
So
clear.
we have just started off with an obese, a little obese donor, short stature. So we thought we might, it will be beneficial for us to do it with robot. We have not done robotic donors too many because financially we don't seeing that it sounds viable for our patients. This patient, as you can see on angiography, has a circumaortic vein and an early branching at 12 mm. So we have just put 4 standard ports as we do for nephrectomies and partial nephrectomies. You can see the 4th port here, which is, you know, elevating the gonadal ureter complex laterally. Patient is a little fatty with the distended colon, so we had a bit of difficulty initially, but now we are okay in the correct plane. We plan to clip the lower smaller vein, which is going retroaortic. So it's a circumaortic vein, and we will use the pre-aortic renal vein for our anastomosis if everything goes according to the plan. If both the veins are of similar caliber or both are big ones, then probably we will have a pantaloon of vein and then join it.
So that is interesting.
If
like,
you have any questions, I'd be happy to answer.
yeah. The two veins, you actually reconstruct them and you don't sacrifice one. So even if both the veins are of the same size, I have traditionally just sacrificed one.
Yeah, you can do that as well, because one vein is enough for the drainage. But our practice is, if they are exactly of the same size and we think that it's a good size kidney and there may be a problem in drainage, then we have done a pantaloon of veins and done an anastomosis as well. So it can be done.
Very nice.
Otherwise, as you said, you can sacrifice one and use the second.
So, Dr. Priyadarshi, like, do you do the reconstruction of veins if you have more than one vein, or?
So till now, I haven't experienced. In the initial years, I used to anastomose 2 separate veins, but now there are certain criteria which I follow, on the basis of which for the past maybe 10 years I have not anastomosed 2 veins or did any kind of reconstruction. Usually one vein is sufficient. Yeah. So what I do is, on the benching table, I can assess the outflow after clamping one vein and see whether the drainage is adequate from the other vein. Or else I might have a temporary ligature or a clip on the vein, perfuse the kidney and see if there is any venous congestion or not, and then take a decision to do the next vein or not. So in the past 10 years, I haven't had problem with doing with the single vein. Yeah. Whatever, irrespective of the caliber, mostly the vein with the larger caliber.
Right. I don't even think about it. Like, I'll just take the larger vein, I'll just sacrifice the smaller or the same size second vein. So it's just easier for the anastomosis.
It's not required, actually.
Yeah.
Samit, can you share the CT angiography or the venous recon of the circumaortic vein?
Yeah, sure, sir. I would request the cameraman to please focus on the CT angio, which is there in the view box.
Especially the venous recon of
the
the
we have the venous reconstruction ready for you on the box. If you want to see the...
That's a lovely circumaortic. You can easily sacrifice the lower one. Yeah. Exactly.
Yeah. So, Dr. Samit, how is the robotic nephrectomy? Is it any different from lap, or it's pretty much the same, except that you're working with a robot?
Minor differences, like you are when you're doing robotic, your field of vision is only this much. So you need to be careful what you're touching, where your instruments are coming from. A robot gives you a wider field of vision. And the second thing, when you are clipping the vessels that it is the job of the assistant rather than the surgeon, because we don't use the robotic clip applicator much. So the assistant you have to rely on the assistant for putting the clips the right way. Rest, I think everything is the same.
Yeah, the two potential difficulties which I can fathom with the robotic nephrectomy, although I haven't done any of them, is number one, if all of a sudden I need to convert. So there could be some time which was taken for the de-docking of the robot and giving the incision. And secondly, after preparing the patient, after doing all the dissection, once you have to give the hilar fan and steel, so with the robot in place, it becomes very difficult to give that incision because of the clustering of the arms of the robot.
Yeah,
one of the reasons why in my hand assist I moved away from the high fan and steel to a low midline was that if you need to convert, you just extend the midline incision and it's like, very simple. In addition to, the arm. So with high fan and steel, I used to have my arm up there. My hand would start cramping in 60 minutes. But with a lower midline, that doesn't happen.
So Samit, we don't have a right angled forceps in the robot. So how do you dissect the arteries? Because right angle...
Sir, you can make these two instruments as right angles, whichever way you want. That's what we do in our partials and nephrectomies, destructive nephrectomies. But yes, you need to be very careful when you're doing that because it's a donor nephrectomy, not a... I feel there's a small artery as well here.
So since you do both laparoscopic and robotic donor nephrectomies, in your opinion, which is easier or better?
Donor nephrectomy, because I have done lot many with the help of laparoscopy only, so I'm more comfortable because I know the vision, the instruments more intimately than in robot, and you need to rely on your assistant more in robotics. So if you have a very good assistance, see sir, right angle.
Yeah.
I think there's another artery here which was not mentioned, going towards the lower pole or maybe the ureter, or it may be a gonadal artery as well. Let me see. Probably gonadal, yeah.
Especially in a case
so I think we will clip the gonadal.
Samit.
Do you agree, sir?
I think you can wait and...
Samit, can you hear me?
Yeah, sir.
In a case like this where you have early branching, 12 mm, a robotic becomes even more dependent on the skill of the assistant you will be having, because he may convert a single stump into a double if he is not very accurate with the placement of the clips.
But fortunately, we have very good assistant, so we can rely on them.
Yeah, the bowel...
Deepak has been assisting us for so many cases, so I have complete faith in him.
Samit,
sir?
The bowel seems to be a bit distended. So
yeah, not a bit, sir. It's hugely distended. We had a really difficult initial phase when we were trying to remove the colon, but we did manage to do that. You're right. The patient has too much of central adiposity.
So just wanted to know, have you done any bowel preparation for this patient or?
No, sir, we don't usually. None of our patients have bowel preparation, the donors.
Really?
But when you get colons like this, you think about that more often than not.
We always do bowel prep in our patients.
Oh.
So initially, we used to do the mechanical bowel preparation, but of late we have shifted to a very light or semi-solid meal in the one night prior.
Okay.
And that helps most of our donors.
I think we have a much higher incidence of chronic constipation. So we have a lot of loaded colon. So if you don't do bowel prep, you're going to struggle in our population.
नहीं ये वे नहीं है ना.
So Dr. Pragnesh, can you hear us in OT8?
Yes, I can hear you. Am I audible?
Yes, yes, you are.
Dr. Pragnesh is having a cakewalk. Beautiful dissection.
Thank you so much, sir.
So we've talked a lot about the surgical technique. So what kind of complications have you seen in your donors, Dr. Pragnesh, with lap transperitoneal nephrectomies?
We have seen lot of complications, but not at our center. Minor complications can occur. Since it's a busy center, we have not seen that much complications here. But yes, sometimes there is a injury into the gonadal vein, sometimes there is injury into the lumbar vein, sometimes IVC injury, sometimes liver injury. Those are superficial injuries.
Right.
Liver injury.
So in my experience, I'll share my experience with complications. I've seen two major complications. So one is usually one of the fellows will start the donor nephrectomy and I join later on. So
we also had the same thing, but we are going to discuss that complication at 12 o'clock today.
Okay.
So I am not disclosing it.
Okay.
So what happened, we did the donor nephrectomy, everything was all right and transplant was done. So 2 days later, the donor started having bile from the drain. So there was an obvious bowel injury. We went back and we saw the recording. So during the port placement, one of the trocars had gone through and through the ileum, and then it was a puncture through and through.
Arvind?
And then the entire surgery was done, the patient was okay, then we re-explored and did an anastomosis, dissection anastomosis. This was one. The other incidence was a splenic injury. So normally after dissection, when you're giving the fan and steel incision down below, you remove all the retractors. We have a 4th port for the retractor, which is a 10 mm port. So once we wanted to harvest, the assistant inserted the fan retractor and straight away punctured the spleen. So all of a sudden, you are a bit negligent and complications happen. So they are the two major complications I had with donor nephrectomies.
So in the hand-assisted technique, like especially when you're freeing the upper pole, the superior pole of the kidney, your fingers are retracting the pancreas. So in the hand-assisted technique, you can have some mild pancreatitis in the post-operative period. So we do check the amylase lipase.
That's interesting. We have never checked in for amylase and lipase. So routinely, what is the incidence of having a higher amylase lipase?
I would say less than 10%, but it depends. Like you have to be really careful using your fingers. We use a lot of fingers for dissection, so that's why it goes faster than a lap, especially in the upper pole. So with the fingers, we are retracting everything up.
Because after any intra-abdominal surgery, amylase and lipase can go up. So without even any insult to the pancreas. So how do you clinically make it significant that this patient had developed a post-laparoscopy pancreatitis or injury?
If the amylase lipase rises more than what you would expect from a normal abdominal surgery. And they'll also have ileus.
Yeah, ileus.
Right angle, please.
Right angle tail का
नहीं गिरेगा इसमें से.
I think another thing in the hand-assisted technique is there's a higher incidence of vasospasm because you're handling the kidney more than you do in laparoscopic. So I often have to use a ml of papaverine after my arterial anastomosis if I'm not getting a good thrill.
पीछे कोई वेन जा रही है देखो, है ना, नंबर है. नजर मत लगा भी
quite well. I started doing it, then I passed it on to my number 2. He's doing very well, and I don't think hand assisted is any more, appreciated nowadays, because you can do a good job by lap itself. And of course, we don't have any experience of robotic donor nephrectomy. Maybe in the days to come, gradually things will change. If not me, maybe my associates will, get onto that. What do you say, Dr. Jha? Am I right?
That's true, sir.
We're all associates. All of us have been working here and there together, learning from each other. The time comes, when the senior teach the juniors, but the time comes when the junior teach to the senior. So you must get into that habit of learning from anyone for that matter.
Absolutely.
Even the good tips can be given by a good macho technician also.
Yeah.
He can hold your hand. No, sir, please don't go ahead. So one should not have the ego.
In fact, OT technicians and nurses, they have seen so many surgeons.
They've seen a lot more. Yeah.
And they see different surgeons operating, say, and they know everything, where to put a full stop.
ये web, that is why करते हैं.
Samit, your kidney is bulkier. The hilum is going to be difficult, looks like.
लेते शांति.
That looks like a lymphatic packet, Samit.
एक और दो, लगाना ही पड़ेगा.
So, Dr. Rajiv, in your experience in patients from the US, how do you see do you find these dense lymphatics around the hilum we very commonly see in Indian patients?
Yeah.
Because of retroperitoneal lymphangitis, they have almost frozen hilum sometimes.
Yeah.
So how is it with your patients?
Yeah, pretty much the same.
So we can see the difference in the hila between the OT8 and
Right angle.
There's a lot of difference between the two hila. So that's the gonadal you are clipping, Samit?
I think Pragnesh is there in the lab.
Gonadal artery, most likely.
दे दो. 5 की मिल सकती थी, 10 की. चलो छोड़ो अभी. कैमरा ठीक करो, अगर दिखेगा नहीं ना मुझे पीछे.
Dr. Samit, was it the gonadal artery you clipped just now?
Can we please connect to the robotic theatre, Dr. Samit? Samit?
Haji sir, can you hear me?
Yeah. ये gonadal artery cut किया है, क्या है ये?
जी, gonadal artery किया सर. ये ऐसे इधर से जा रही थी. Upper pole is high. I've seen it from behind. It's not going towards the pole, so I have sacrificed it.
Dr. Rajiv, what is your protocol or practice regarding the gonadal artery, cutting the gonadal artery or sacrificing the gonadal artery, especially in younger male donors?
If it's in your way, we usually sacrifice it. If it is not, try not to sacrifice it.
Many a times I've seen, maybe sirs can answer, chronic orcalgia develops in patients, especially young males after donor nephrectomy. maybe in 2-4%, but that's very nagging.
I haven't.
Archalgia in donors, maybe that they don't come. I don't know about that, but I have hardly ever seen. I don't know about.
I have never
we
seen.
have never seen that. Well, but then when the artery comes like this, it's very difficult to save these arteries.
Yeah, if it's new,
And
you take it.
you have other circulation to the testes. I think
Normally
that
we don't get.
normally you don't get such a robust testicular artery. And then it's a question as to what will you do with this? How will you save it?
You can't.
And and if you save,
इसको भी clip कर दें.
what will you do with that? It's a little difficult. I don't know. It's a difficult question to answer. The best thing is to sacrifice it and go ahead, because that time.
एक ऊपर भी.
We have to give the priority to the donor nephrectomy actually.
Somebody may come with a question, somebody may come, well, if such a robust artery, there may be a supply to the ureter. Somebody can come with that question. But then the ureteric blood supply is a very good blood supply. And if you keep all the tissues around ureter and maintain the golden triangle, it's hardly ever you will end up in ureteric problems. I've seen the first time when I saw Pranjal Modi doing laparoscopic renal transplant and of course donor nephrectomy. So I found that the ureter which he harvested was looking to me very skinny, So I thought, because always we used to keep good amount of tissue around the ureter. We were taught that, we practiced that, and we never had any problems. I was a little surprised. But then I found that all his cases were doing so well. We said, look here, once in a while, if you don't have such a good, rich periureteric tissue, don't get into tension. There are other things to look after. Yes, intentionally you don't skeletonize the ureter. That should be there in your mind. But sometimes it happens, Yeah. It just happens. And then you are thinking all the time.
Yeah. In fact, one more modification which I've started doing now is, which I learned from Dr. Johari, was that keep the ureter as short as possible. Initially, we used to harvest a very long length of ureter, and we were very happy that a lot of tissue is there. But now, I keep the ureter to the shortest possible length so that it reaches the bladder.
Yeah, I do exactly the same. I keep a very short ureter.
Yeah, you can decide it after you have done the. He's right.
After reperfusion.
After reperfusion.
I think for harvesting, you must harvest the ureteric length as much as you can. It is comfortable to you and to the patient. And then, after all, it is ureter. Then you see how much length you really need it. It's always good to have half a centimeter, 1 centimeter, little extra as compared to absolutely tight, because the bladder is collapsed at that time.
Yes.
And you must give some allowance for this ureter to behave when the bladder is distending, contracting, distending. And that should be there in the mind, which is a common sense, I think.
Yeah.
Because you have distended the bladder and you have just anastomosed. When it is collapsing, there is a tension on the ureter. So that has to be taken care of.
So Samit,
Sir,
looks like a very difficult hilum. You have a circumaortic vein. You have identified the circumaortic collar, or?
no, not yet. The lower vein I have not. The anterior vein is here. The posterior one, because there is a big lymphatic, probably here we will be able to see.
So this patient must be from either UP or Bihar, the donor. Usually. Yeah, exactly.
Yes. Lot of adhesions you will find at the hilum if patient is coming from Bihar or Eastern UP.
Mostly, probably because
Tough lymphatics and adherent to the veins and arteries. This we are every day we are anticipating once we are doing any nephrectomy. Particularly Bihar and UP.
Mostly because मुझे लगता है सर ये लोग बाहर सोते हैं तो नंगे पैर सोते हैं तो मच्छर इनके पैर में बहुत काटते हैं.
Filariasis is very common. Chyluria, in BHU we had a 30 thesis on chyluria only. Such a common problem, chyluria. Chyluria and filariasis is very common, rampant, endemic actually.
So we don't have a hook in the robot, Samit? So I think Sir is there, Professor Anant is there for the donor.
And this is a difficult nephrectomy robotic.
Yeah, especially when we are not doing it routinely. So it's like a one-off case, just for demonstration purpose.
To get a better view.
Abhi the hilum is quite frozen, so
Sir,
it would be difficult to flip.
We'll not finding proper plane. If we'll partly flip, at least we can see the artery directly.
In fact, I believe flipping would make it more difficult because the kidney will start falling over the hilum. So
that can be handled with the perinephric Girota holding. Girota is preserved. Maybe I'm wrong in just...
So Dr. Anand, there is a question from the audience about flipping the kidney at this stage. If this dissection is difficult, why not flip it? That's the exact question, right?
Yeah.
So please connect us to Dr. Anand Kumar, sir.
Can you please connect us to OT12?
So are we connected to OT12?
Hello.
Good morning, Dr. Anand.
Good morning, good morning. Now you can repeat the question.
Yeah, so somebody asked a question about flipping the kidney at this stage because it looks like the dissection seems to be difficult here.
Now this we are little careful because there is a one, have you seen the NGO, no?
Yes, yes.
There is a retroaortic or there is another vein which is going down. So I'm just looking for that. That vein should not be the one we are looking for. इसको ऐसे करो. ये तो ऊपर वाली है. I will see, don't worry. We'll find it out where it is.
So I'd asked one question to
Maybe
Dr. Samit.
it is somewhere here.
So I'd asked this question to Dr. Samit earlier, Dr. Anant.
Yeah.
You, since you do both laparoscopic and robotic donor nephrectomies, which one would you prefer if you had a choice, especially in a more difficult case?
No, we don't do robotic donor nephrectomy. We are just for the conference, we are doing it that people can get idea. There is to my mind, there is no advantage of doing a robotic donor nephrectomy. Laparoscopic donor nephrectomy is very straightforward, and why to pay extra for that? But those who have difficulty in doing laparoscopic donor nephrectomy, robotic will be easier and faster to learn in comparison to the laparoscopic. So that may be the one indication. And in a very complex one, yes, one can choose like we have chosen for the horseshoe kidney. And otherwise, laparoscopic donor nephrectomy is a straightforward operation, and we always do it, and we like to do it, and probably robotic with apart from the extra cost, patient will have some extra port also, and laparoscopic will have less port. So, and in laparoscopic, surgeon have all the control applying clip as he wants. Here the clip application will be with the assistant. So if you have a good assistant, then you have no problem. If the assistant is not very well experienced, then maybe there may be some problem. So that's what I believe. But what is happening in lot of centers where robot and money is not a problem, there they have started doing robotic. Like when we were in Switzerland, they were doing robotic retroperitoneal robotic donor nephrectomy routinely, and now in America many centers are doing robotic retroperitoneal robotic donor nephrectomy.
Yeah, in US, a lot of programs do robotic nephrectomies in preparation to gain the robotic skills, so they can,
yeah, that's a good thing to do.
Yeah, to graduate to doing robotic kidney transplants.
Maybe I might just release this one also.
Yeah, we don't look at the cost about anything.
But we have to consider the cost factor also.
Yeah.
I mean, we can't say that we are doing this for learning for our this thing.
Yeah, maybe after looking at, you can see that sometimes you should do something which not to be done. So probably this may be not to be done. But many centers are doing it, and now they claim it total robotic transplant. So the name they have given is total robotic transplant.
The way this evolves in US programs is they start with robotic donor nephrectomies. Once they learn robotic kidney transplant, then they go back to doing lap nephrectomy and robotic kidney transplant.
Sir, in US, what would be the approximate percentage of patients undergoing robotic transplant versus open transplant? Like how common is it?
5% or less.
Okay. So it's still uncommon there as well.
Very uncommon there, yeah. Very few. You can count the number of programs on your fingers. It's like very few programs that do robotic kidney transplant on a regular basis. Out of total 300 kidney transplant programs in US, I would say maybe 10 are doing this on a regular basis. So not even 5%. So.
Maybe now my exposure may become little better. I was just trying to. थोड़ा सा इसको ऐसे करो, जरा इसको बाइपोलर करना है मेरे को, इसको ऐसे करो. नीमो कितना है? ठीक.
What a contrast between OT8 and OT12 in terms of the two donors. One is so easy, one is so difficult.
I think that patient is a difficult patient, OT12.
Yeah.
So Dr. Rajiv, what is your practice regarding the adrenal? How do you dissect the adrenal and separate it from the upper pole of the kidney? Do you come from lateral towards medial side?
No. So in the hand assist, you have the advantage of your fingers in there, right? So you try to expose, like I start, after I've taken the, first I dissect the renal vein, I take the adrenal branch, and after that, with my fingers, I will retract that tissue just above the hilum on the, superior pole, superior-medial aspect. And then I start taking tissues. There are lots of little perforators that will go from adrenal into the kidney. So you just take all those with ligature and just keep going up. So I've already taken half of the superior pole from the middle of the kidney to the diaphragm in the first step of my, exposure. So this is the only thing that is left. It's very easy, like with fingers you're able to retract it. So I usually never encounter any problem in that. The advantage of hand is I also have a lap in there. So
one hand is better than many instruments, but the only thing we don't do hand assisted is the cost of the port. That is the one reason.
Yeah, I never realized it was so expensive. The way we use things in US and throw them, sometimes open it and don't use it. It's just amazing.
IBC दिख गया, ये out है.
Dr. Tanabe is also in your OR, I think, right?
He is in the OR.
So I think this is the best way to make the hilum dissected. Once we have a thick lymphatic, I also graze on the surface of the aorta, lateral surface of the aorta, rather than just medial to the ureter, because many times when the hilum is too thick, it is very difficult to enter the hilum. So I also start bearing the aorta from below and graze it upwards.
Yeah, I never try to dissect artery anteriorly. I always do the artery from the back. After I have, dissected the vein and got the upper pole off, then I don't try to look at the artery from the front. I'll just flip the kidney, take the lateral attachments off, flip the kidney, and then palpate where the artery is, take everything lateral to that, up to the abdominal wall, and then just use a very small segment of the artery, enough to put a staple in. Because the more you dissect your artery, the more the vasospasm that you have. When I was training, we used to use the TA staplers, but after I started doing these things as an attending, I just use the echelon flex vascular.
So like in our, we won't be dissecting more except the origin of the renal artery. We won't be dissecting and going towards the hilum.
Yeah.
Only this much dissection so that we can apply
the clip.
this Hemolock clamps, that's all.
Where's the circumaortic branch, sir? We can't see
it. We haven't found it.
Okay.
I'm just wondering, probably I'm just going to look for it.
Yeah, we were talking about vasospasm in the donor kidney following retrieval or at the time of reperfusion.
So that's what I say. If you do this kind of dissection, there won't be any vasospasm. Vasospasm comes when you try to lift the renal artery, pull the renal artery, stretch the renal artery. So we don't do it. What we do, we just do the para dissection, then we might put the. Okay, I'm going to look for that vein. Probably this is the vein which is going like that. I'll just see. This should be somewhere here. Okay. So clip लगाना पड़ेगा. These are the big lymphatics. एक यहाँ पर क्लिप लगाओ. वो बहुत बड़ा है. हाँ, मतलब छोटा तो पीछे करो. हाँ, लगा दो.
Sometimes the hilum is so frozen, we have a big lymph node sitting over the artery, which is...
I have never seen a lymph node sitting over the artery in the hilum. And these lymphatics are a little bit more than what we would find. So I was telling you earlier, this is what we do. So as after you reflected the bowel and everything, I will go like this through the Girota. And then from here, I will take everything, free the upper pole, and then I'll clean the vein, take the adrenal with the ligature. Then I'll start.
Got the vein.
Taking the tissues from here, and from here through here.
That's the vein.
And then I will reflect the kidney.
Normally, so what I'll do is, because we don't open the Girota, probably you take out the kidney in the endo catch bag.
No, with the hand.
So
it's
can you just put some clip here? Put clip here.
Yeah, we take out with all the fat.
Yeah, fat, and I'll just, once I cut the vein, I'll put my suction inside through and through. So once I put the suction, tent it up, and then
just to prevent some lymphatic leak.
Provide retraction here, and from here, then I'll start taking all those tiny perforators here, and you just have to go from here through here, and then it's separate. The reason we do this first step here is so that the spleen falls off.
Spleen, I'm also very particular about breaking that
sooner
attachment.
it falls off, the less the chances of splenic injury.
So as compared to the main renal vein, this looks pretty rudimentary. So I think this can be sacrificed.
We'll be just clipping it.
Yeah, maybe a dilated lumbar which is crossing.
Yeah, looks more like a lumbar vein.
Yeah, you're right. It is like serving the purpose of lumbar vein.
So mostly that retroaortic collar usually looks robust on the CT scan, but in the intraoperative it is very small. And most of the times, almost all the times, we can clip it. Yeah, if it's a collar. If it's the vein, it is a thick vein, but if it's a collar, the anterior channel is quite robust.
Okay, you can bring a Hemlock clip. 5 का ले आओ, लगा दे 2.
So yesterday in the video that Dr. Tanabe showed, we saw him taking the ureter with ligature. When I was training in Northwestern, that's what almost all of my attendings did. They would take the ureter with ligature. Never had any problems, but as an attending, I never had the courage to take ureter with ligature. I would still clip the ureter. Does anyone here take the ureter with ligature?
No.
No, that only thing, if you take the ureter with ligature, you have to make sure that you excise the good part of the ureter from the resected margin and make it bleeding nicely.
Yep.
That's all. Otherwise, there should not be any problem with taking with. You can put a clip here. This is just to avoid any lymphatic leak.
So what is your experience about the left side IVC? How do you tackle?
We had encountered this problem, and I think we have the video of that also. It was just sinus. This was a sinus invertus, and just because we knew it, there was no problem in doing it. Just do it like that. Okay, so my artery is prepared. Now I'll prepare. We got the aberrant vein. I'll just look for the suprarenal and other things here. That's the suprarenal. दीपक लिगाश्योर लगवाया है? हाँ? नहीं लगवाया? लगवा लेते तो हम सुप्रारीनल को ले लेते लिगाश्योर से. Okay, come here. Just put it like that. In laparoscopic donor, number of times suprarenal and gonadal we have taken with the harmonic. Same way like people take with ligature, because you are using harmonic. If you bring the ligature probe again, so hospital will charge.
Oh, okay.
Yeah, a thin vein can be easily taken with harmonic.
So, but that here we'll just put the Hemlock 5 mm Hemlock clip. इसको जरा ऐसे करो. Okay. So I just wanted to mobilize little bit more here for you. Okay, लगाओ. ऊपर लगा दे पहले. ऊपर और ऊपर. हाँ, यहाँ लगा दे.
Yesterday, Dr. Ruchir was telling us about the Hemlock experience here in India. I think you should publish it because
whenever we try to publish it, it is my all paper on transplantation have been rejected because we have been taking the They say that paper is good, but since you are using Hemlock clip, which is not allowed, so we cannot publish it. So so we publish some of them in Indian Journal of Urology, European Urology, and European journals and American journals. They all refused because of this, and very good studies. So all they were finally published in Indian Journal of Urology or Indian Journal of Transplantation, and so they read it, they appreciate it, and they return it very politely. So, and we have done one survey. Ruchir has done one survey.
Yeah, he was telling us about
they
it.
have asked the people, and most of the in Asia and India and Asian country and some of the European country, they are using Hemolacca. But only thing, yes, something has happened in the past. There is no doubt about it. So one has to be careful. One has to find out the answer to that. And I'll tell you, I have seen the stapler problem also. There was one patient, Dr. Pokhar Das Gupta was doing radical nephrectomy in Calcutta, and he fired it and he can't open it, and that got stuck. So finally, what I have to do? So he called me. I was in audience, so we opened up, and we have to resect that part of the vein along with the stapler. Only then stapler come out, and then I have to repair the vein.
Wow.
In fact, I have also seen a lot of problems with staplers. That is why I'm afraid of using them.
We don't use Hemolocks at all in US.
So
in any nephrectomy, even a radical
So
nephrectomy.
I don't do those nephrectomies because
Then
I'm
if
not
for,
a
as
general
such, because for donor specific, they are not ready. For donor, they are absolutely refusing.
FDA has issued a very clear-cut black box warning for Hemolock.
Only for donor or for any
for all.
any vascular.
Only for the donor. Same Hemolock clip is used for radical nephrectomy.
It is only for donor, not for everybody.
Only for the donor. Hemolock is routinely used for the all kinds of nephrectomy, all kinds of other dissection. Except in donor, they refused it because I think 2 cases happened in America, and I think 1 or 2 happened in
Means
Europe.
they are thinking donor is more precious than a routine patient who is going into radical nephrectomy.
Yeah, that's the question.
Because the risk remains the same to the...
Remain the same for everybody.
For everybody.
I'll tell you, there was a debate in America, and so one of the Pranjal Modi was and I supported him, but the whole audience was against us, like we are criminals. They just very, very vehemently and with some bad language, they thought that we don't care for the human life. And when we asked that you're using for radical nephrectomy and all that, are they are not the patient? There are you not? So you should not let the Hemolock clip be applied anywhere. But then
I think the reason for the black box
that
warning
debate,
specifically for donors.
Rather, Pranjal was humiliated, and I have to get up to support him. And then they were against me also, but at least we fought the war there.
Good.
So I think the reason for the black box warning on donors is that in donors we apply our clips a little differently from in a ablative nephrectomy. Like radical nephrectomy, you're not struggling for a long common stump. You're not applying them flush on the aorta. You can put the clips wherever you want. Put 3 clips. Whereas in the donor nephrectomy, you're going low down the aorta. In an early branch, you may be trying to force your clips together. So I think that is the reason. I mean, to my mind, wet clip failures are all human failures. And they happen in donor nephrectomy because of those imperatives of donor nephrectomy that are not there in other ablative nephrectomies. So that's the reason why problems occur in donors, which will not necessarily occur in a radical or other nephrectomy.
But the only issue is because whole medical science is on the experiences. In India, so many transplants are being done, so many thousands, you may say, with the Hemolocks. So they should accept this truth also.
Yeah, that's why I was saying, like, you should have to publish this experience. So
the question is, what is he telling? Publication, they will not accept. That is the problem.
The publication can only be in the Indian Journal of Urology.
This
and
is their monopoly, that's all.
There has been publications are already there, but this survey, I don't know why Ruchir has not published it yet.
Anant, I have a small question.
Yeah.
Have anybody come across this psoas muscle like a tendon hitching over the renal artery while doing the laparoscopic donor nephrectomy and giving us a lot of problems to put the clips for the renal artery? I have recorded that. I have never come across this type of situation ever before. That it was hitching so badly, it was looking like a normal tendon of any other muscle, which is overriding the aorta and hitching the artery, becoming very difficult to retract the tendon to get onto the base of the renal artery. Has anybody come across with that situation?
No. Was it the tendon of the psoas or the crus of the diaphragm?
Yeah,
because many a time.
No, diaphragm very far away.
No, sir.
The crus of the diaphragm usually comes.
The left crus of the diaphragm that overrides the origin of the left renal artery.
Many a times.
And if you see a CT, very often the renal arteries emerge very close to the SMA and very rarely even above it. So there can be an abnormally high, the problem is actually with the high origin of the artery, not with the crus. And when it's a higher origin, it will come and root under the crus and cause the problems that you're describing. But well, it's fairly simple to just incise the crust using cautery, and that usually takes care.
Agreed. We had not come across this type of situation before. I must have done thousands of open donor nephrectomies, but during laparoscopic surgery, when we saw this thing, during open surgery you can do anything, you can flip the kidney here and there. So we had difficulties. I, of course, didn't strike my mind that it could be the crus of the diaphragm. We thought it is but it was very long, going all along over the aorta. Could be anything, anatomical abnormality, and but we could get over without incising the particular tendon or crus of the diaphragm, whatever you may call. Well, in future, if we come across, then we will be more radical with the tendinous structure.
Sir, renal artery ke upar, Dr. Bhatyal is saying that he has encountered a strong tendon-like structure such as a psoas minor tendon or maybe the crus of the diaphragm. So what is your experience about it and how do you tackle it?
I have not seen that.
That's it.
So when it will come, when we'll see that, now I remember whom to contact.
No, Anand, we just got over without playing with that.
At least good, at least you have told us this. If we encounter, at least we know how to get out of it or what to do.
Crus, I have also incised twice.
No, we just mobilize the kidney completely before clamping this thing. We keep only very little tissue at the upper pole so that the kidney doesn't, we are not bothered by clamping the vessels. So it was okay.
Regarding Humalog, the case that actually led to that, Humalogs not being used in US was by Tom Bach, who's a good friend. He's in the University of Colorado in Denver. And that was like during Igal Kam days, one of the early, the liver guys. And what happened was they, he put the Humalog clips and he was able to get the kidney out. Everything looked good at the time. Tom Bach has experience of over 2,500 lap nephrectomy. So he's one of the guys who's done maximum numbers in US. In the post-operative period, there was a hemoglobin drop. The patient was brought back to the OR, and they saw that the clip had slipped.
But in that case, only one clip was applied.
I think so. And
yes,
then they
only
called
one
the company.
Clip. I know about that case. Only one clip was applied.
Yeah. And then they fought with the company. Igal Kam was a very powerful transplant figure in those days, so they really got that company penalized for that slip.
In fact,
the patient survived. Nothing happened to the patient.
I've seen more problems with the XL Hemolock clip rather than the normal medium sized which we use. The golden one tend to get more twisted or sometimes.
Yeah,
So
I have no experience
I
using
use
Hemolock
only
clips,
the
so.
purple clip only.
Okay.
Yeah, I don't use that. Hemolock. Purple. Purple.
Sometimes the vein will not snug.
Then the extra
purple.
large, then the golden one.
So, and do you use two? Use a Liga and then a
No,
Hemolock?
only 2 Hemolocks.
Just 2 Hemolock.
Just 2.
The vein should not be a big problem. Artery, because there's a lot of pressure in the aorta.
Once the artery is clamped, the vein shrinks mostly.
No, but on the right side, the shrinkage of the vein is very minimal because of IVC. But I just want to know, have you encountered problems with the staplers? And what kind of problems have you? We have known that once the stapler didn't open, and then the surgeon was struggling. In India, there was a case presentation. After that, I'm very scared. I don't use that stapler. So, have you ever come across problems of staplers?
I have not.
Have you heard the classical story of Cleveland Clinic? The story is Ralph Clement, who is the person who started donor nephrectomy in America, very renowned. So in Cleveland Clinic, there was an operative workshop and for right radical nephrectomy. So he fired the stapler and cut it. But the stapler did not cut out, knife cut the renal vein. And you know that now there was a bleeding. And then patient required 90 transfusion.
No.
And he was in the hospital for 6 weeks.
Wow.
And then 1 million, or I don't know how many million lawsuit was filed, which Cleveland Clinic has paid. And after that, they made the rule in all operative workshop, only Cleveland Clinic faculty will operate, nobody else will operate. So this is, and I told you the one incidence in Calcutta, Pokhar Das Gupta was doing radical nephrectomy, he got stuck, stapler fired but it won't open. So he called me and I scrubbed and I had to resect that part of the vein with the stapler, put the proximal distal vesicular clamp and then repair it later on.
Sir.
So
I think I've been fortunate.
These are the two things at least I know.
What stapler?
Dr. Neeraj was telling same thing happened with him recent 2 months back in Subjung Hospital. The IVC end of the stapler did not actually close the IVC. It caught and there was its massive leak from the IVC, 2,500 ml blood loss. But patient survived.
On the right side.
Echelon Flex powered stapler.
3-3.
2-2.
2-2.
Yeah, and it has a manual override, so it's a powered stapler, so it's automatic. But if it doesn't open, you just do the manual override and it'll open.
So we use that stapler
white or a
for
blue
very
sorry, it has vascular 3.5.
Yeah, when the vein is quite big, especially in the radical nephrectomy in tumor, or when there is a tumor thrombus, a renal vein thrombus going up to the IVC edge, you fire it. So that's very safe. So we have been using it. But what I know and what I have seen, I'm just telling you. But so what I'm saying that, and I was presenting I was giving a lecture in Gynecological Society about the complications of the robotic surgery. And when I started doing the search, it was very interesting to see how many complication has happened. And it was very large number of complication, including stapler fire, robotic malfunction. I have that presentation with me. It's a huge one. And it's eye-opening that even with the robot, a lot of problems happen. There are different gates, but all kinds of problem happened in robot, and deaths have happened in robotic surgeries. And this is all in the website.
So Dr. Tanabe showed us his technique where he used the GIA. Anyone else uses the GIA for this? No.
So we've used one stapler which is originating from China.
Is from IKDRC. If Jamal is there, he can tell us. They have developed a technique of GI stapler. They take the clip of one side and fire it over the right renal vein, so that only one side stapler is there. Other side they have already removed, and then they cut it.
Yeah, right, sir. I'm here. So this was actually, we talked yesterday about stapler shortages in India. And there was a time when the only stapler available to us was a Johnson stapler firing 6 rows without a knife. Now, we used it. We found that those additional 3 rows were really shortening our right donor renal vein. So we found that we were able to, using a needle, to tease out the pins from the distal 3 rows of the stapler and convert the 6 rows into 3 rows. And for several years, we used that over about 30 cases. And it worked quite well. We sent it for publication. Fortunately, several editors wanted us to get a disclaimer and a permission from the company that they were okay with us modifying the stapler, and that, of course, couldn't happen. Although this is, we were inspired to do this by an earlier, I think, 2008 paper from Belgium, I think, by Dr. Bollins, in which they've done a similar modification in a different make of stapler. So there is a precedent for this. But again, it was not accepted at all. And now that even that stapler is no longer available, it's probably not that relevant.
Can we go to OT8?
Many times everybody says that editors, they are biased for various reasons, and it's not that only, because many publications have not been accepted for various reasons.
Please switch to the OT number 8.
OT8 Summit is doing extra
So Shivam, have you, Shivam? Dr. Shivam? Hi. So have you had any experience with the other staplers? So there's one stapler.
Dr. Prinesh,
Yes.
over to you.
Tried them?
Can you hear me?
No, never. So they're coming out cheaper by about 20% or 25% compared to
Find out वहाँ पे पता करो जरा कि बेड तैयार है, ट्रांसप्लांट बेड तैयार है, पूछो.
Some of the advantages you don't
यहाँ से वो कहाँ गया, माप दो ना.
for each size of cartridge. Then,
गिर गया क्या?
you get them powered or manual, and they are coming in all the sizes. We've used them when we are doing bladder robotically. We use them once when we are doing IVC thrombus. So these are some alternatives which you are now getting.
Fluid कितने चले गए? Fluid? पक्का? ये 5वां है. दे दो fast. हाँ, निकाला? Hello.
Yes, Dr. Pragnesh.
So we are ready with the retrieval. We have done all the dissection. We have given the incision penicillin. And now we are about to. Sister, give me 10 mm clip for ureter.
Has the extraperitoneal recipient started?
Bas.
Robotic.
So this time I have kept 2 light source standby.
Robot.
Because of the yesterday's incidents.
Light source went off at
After
the time of
artery was
clipping.
clipped, the light source went off.
The whole endotar stopped.
These things only happen during workshops.
That is why, sir, in workshops only that person should operate who is from that center, because he knows the nitty-gritty of all the instruments.
Wait karo. Ureter pe focus karna beta.
That's important.
Many a times it happens that you are at a critical moment and somebody walks across and pulls the wire from the leg. So that is why I close the doors of the OT when I clip the artery. No movement should be there.
So are we in this OT8 we are waiting for urine to from this? Is there any significance for this?
Yeah, at least I would also wait till we have an active diuresis, because an actively diuresing kidney is likely to suffer the least insult when you are transplanting. So I would also wait till the time the spasm recovers and the kidney starts actually good diuresis before the harvest. Yeah. Although there are two schools of thought, many surgeons don't follow that rule, but we have always stuck to this principle.
Yeah, so I think I would be from the other school of thought. I mean, see, you know, you've evaluated your kidney, you know the function, you know the vascularity. You also know why it is soft and why there's no output because of spasm. So by waiting for it to, put papaverine, wait, you know, that ischemia continues, then you have some revascularization there, so there's some sort of reperfusion insult. Then you clamp it. It's better just to take it out as quickly as you can. Yeah. Just allow it all to become one episode of ischemia, and then, you know, it will recover. Just the fact that your kidney was a little in spasm and blue on table doesn't mean that it will be the same after opening your clamps.
So I agree with Dr. Jamal. We also do not follow the diuresis on right side. We used to clip the pedicle first, then the ureter. So we don't observe the diuresis on the right side. But since it's a tradition to observe the diuresis on the left side, so we are following it.
Yeah, it looks nice in the workshops, you know, that the ureter is diuresing. But of late, we have stopped cutting the ureter first. We just take off the pedicle and then we cut the ureter, because it becomes easier for us. The kidney doesn't fall down. So we find that operatively, it becomes easier to handle the pedicle.
Give me right angle first.
And nothing has happened ever. Right and left. We don't do right laparoscopically, because I'm very scared of putting the clips on the vein and then getting a vein. I personally feel I must give a good transplant result. So getting a small little renal vein and then struggling and then sometimes reconstructing it, I don't believe in that. And I told you about the experience of stapler, so I'm very scared of that. I think the scare is saving me.
So how much fluids do you give these patients until this point, Dr. Pragnesh?
Approximately 2 liters, minimum 2 liters.
And do you use some Lasix, mannitol, etc.?
Yes. Yeah. At the time of hilar dissection, after bowel dissection or dropping the bowel, they used to give mannitol.
You see, about the fluid, hydration of the donor and the recipient. Recipient all depends upon his cardiac condition. Okay, but if he is well preserved and the donor, 15 ml per kg per hour is the fluid to be given. It is documented everywhere. So for a normal person of 60 kg also, it is about 2.5 liters for both, unless of course the cardiac condition doesn't permit. Yes. Then you may have to give 1 liter, you may have to give 1.5 liter, depending on that.
Yeah. No, sir,
that is what it is.
I would beg to differ on that. In the recipient, what we follow is how much ultrafiltrate is being removed in the previous dialysis. So mostly the surgeon should be aware that one night before the prior dialysis, some recipient will have 3 liters of UF, somebody will have just 500 ml of UF. So we should be overloading the patient at least 1.5 to 2 liters over and above the UF which has been removed before the previous night, rather than following a simple protocol.
No, it amounts to that. You will see it in your own patients. You will never go beyond 3 liters. Because the anesthetist will also say that we're going to have problems. Yes, once the diuresis has started, we can look after that part.
But mostly, sir, if many a times the nephrologist would remove, say, 3.5, 4 liters, so I usually prefer to load the patient, at least make him isovolumic, then load him above. So many a times we have given 5 liters plus at the time of clamp release.
So Ranjan, regarding this point of observing the diuresis, before the kidney is finally, the pedicle is clipped. So there are different practices, as we were just discussing. Dr. Bhatia said that they would not cut the ureter because they would not like the kidney to flip. I think that's the idea. If you cut the... So an alternative is to cut the ureter, see the diuresis, but leave the gonadal vein intact. Just keep it clipped so that just in a flip of a second you can cut it afterwards. So instead of keeping ureter also intact, I prefer, and I think most of us would like to see the diuresis, whether it is there or not, and should we retrieve the kidney at that moment, that is again an individual choice. But one thing is clear, that if the urine is not coming, intrarenal spasm has set in. Right. Now, once you transplant this kidney, at that time there can be two things. Sometimes we have observed that the diuresis starts late. And even partial ATNs have also been reported. So these are the things, I mean, there is a lot by logic, there is no literature evidence as such. But I think by and large, if you could wait for some time, maybe put little papaverine, keep the kidney straight, and watch for diuresis, as you have seen here. After some time it has come, and then put the clips. Probably that's a better idea.
Another reason for which I follow this is because I never know what is going to be my anastomosis time. It could be 15 minutes, it could be 3 hours also. So that is why I'm very particular that I clip only a diuresing kidney.
Yeah, that's the...
Yeah, I follow what Dr. Jamal said. I don't wait. We'll just take it out and deal with it in the recipient. Give some papaverine if you have to for the vasospasm. And it's a living donor kidney. It is going to work. I mean,
I think regarding on-table spasm, I mean, the thing about vascular spasm is an active process. The musculature of the artery is contracting. Once you clamp the kidney, you stop the blood supply, you put it in cold ischemia, all that ATP is depleted, and spasm is anyway going to relax. So I think just because your kidney has opened up after waiting in papaverine doesn't mean that it will not go into spasm again later. And the corollary is that a kidney that is on spasm on table will not necessarily be on spasm after opening the clamps. I mean, I think at least in our experience, there's not a lot of correlation between the turgidity of the kidney at the time of donor and after opening the clamps.
I hope there are problem.
I think there are a lot of surgeons in US who actually, the old-fashioned ones, they will wait until they see a good diuresis. They'll give more fluids, they'll do everything, and the kidney only comes out after you see urine.
Why do you call them old-fashioned?
I mean, what's the point? You've already cut you've already evaluated the kidney. It's a good kidney. And whatever is happening is temporary. It's ATN because of what you're doing. ATN will always resolve unless it is superimposed on a long cold time, long warm time, or a chronic injury. So there's no point waiting, right? Why do you want to wait? Just take it out, put it in, deal with it in the recipient.
ऐसा कोई प्रॉब्लम है नहीं, छोटी मोटी ट्विग है। हाँ चलो इधर लगाओ, पकड़ो पकड़ो आराम से, है ना। और ये आपको लबड़ा क्लिप दो।
I think for the vasospasm, does anybody here use papaverine in the recipient if your kid... yeah. So I usually inject about a ml in the adventitia of the artery if the kidney is not opening up as I would expect it to.
This was very common in UK. She used to infiltrate.
Yeah.
So that was...
Long clip.
So before papaverine, I put some warm saline to...
No, they used papaverine along with the... But in the adventitia, making a little angle and then infiltration.
But the spasm is intrarenal, sir. It is not in the main renal artery. Spasm is intrarenal.
Intrarenal.
But once kidney has been
So either you give it intravascular, because injecting just in the adventitia, which is not going to relieve the intrarenal spasm.
Lymphatic type का था ना, उसमें clip लगी थोड़ी सी ऐसे खींच गया. चलो ये निकालो.
So many a times hot saline works for me. So I just.
A lot of times people will wet a gauze and papaverine and just wrap it around the renal artery. I've seen that too.
No, it is only we have declam and the artery position is not so good.
चना मुझे तो तू जाने बेटा.
Again you find the artery dilated and.
मैं कभी नहीं बोलता लाने के लिए इतनी जल्दी इसको परेशान होने की जरूरत.
One of the theoretical objections to injecting into between the adventitia and media is, sometimes you might have a little bit of dissection and it's better, I think, to just pour it on to the artery and it works because ultimately
In fact, at that time,
सुनो,
there are
यहाँ
so
पे
many
surface view दे दो.
the volume status of the recipient, the angle of the artery. So there are so many variables to tackle rather than just the spasm.
वेन जहाँ लगाई है ना, वहाँ पे हल्का सा उलझेंगे मोस्ट प्रोबेबली तो पेरी आर्टरियल जो लिम्फेटिक्स होते हैं उसमें से है. वो देखने के लिए बुलाया. बेटा ऊपर लिखा ना करके सीधे. हाँ जूम इन करो और सरफेस व्यू दिखाओ वहाँ बोलो.
Dr. Bhatiyal, to your just the comment on the right-sided, renal vein, and that you are very apprehensive about clipping. So you would rather like to give a small incision and then retrieve, even after doing everything laparoscopically. So one of the ways which I look at, that first thing is you go with your radiologist to the preoperative CT and look at the length of the renal vein. On the right side we are talking about. It varies. Actually sometimes it is even up to a centimeter long only. And then we have seen it is 3.5 centimeters also. So that is one thing which we should know preoperatively, and obviously where the conference from the upper pole and the common opening. And second thing is when you are, as you are doing laparoscopically, you can actually assess the how thick is the wall. If you can see the column of blood moving inside, and I know with all our experience of between the left side vein and the right side. The left side you will never see, you will see a straight vein, there is no moving column. If you see that, that means this wall is very thin. So if you have a short vein, or even if a little longer vein and a thin wall, that's how you predict with that. Then probably better not to clip it. Otherwise, we have clipped it and like put 2 hemologs and it works well.
I fully agree with you. I think I am obsessed with the collar of IVC. It is so robust that I take pleasure in suturing that thing. And I totally agree with you. One has to understand these things. We all go and discuss with the radiologist about both arterial and venous anatomy. But I am very frank in saying that I am really obsessed with the collar of IVC, which gives you a very stout site of anastomosis. And I love it. Thank you.
But sir, why is this that the thickness of right renal vein is unpredictable most of the time? Sometimes it is very flimsy, sometimes it is okay. Left renal vein is always okay, most of the times, more than 90% of the times. But why does it happen? Is there some physiological or anatomical reason behind it? Many a times right renal vein is just like a wet sheet of paper.
See, the left renal vein gets thumped. Every second the left renal vein is getting thumped from behind by the aorta. So aorta keeps on thumping it from behind. That's why probably it is thicker than the right renal vein.
Uski pitai hoti rehti hai. The God has made it like that. It's very difficult to give both the thickness of the vein and the length of the vein.
Yeah, exactly.
And sometimes, of course, multiplication, that you may have 2, you may have even 3 sometimes, and how far away they are, Whether in open, of course, you can take a wider cuff, no problem. But while doing laparoscopy and then, of course, your robotic, there can be challenges which have to be taken care of.
Yes.
Regarding the right renal vein, I was talking with Dr. Lloyd Ratner. So Lloyd did the first lap nephrectomy in the world in 1995, and he has a very good experience. So he said that he uses staplers, but he'll do a V-shaped staple on the cava. So one from below, one from top. To get a cuff of cava. I never tried that. But
how does he get it from above? Does he have a second large port higher up? It seems very strange.
Yeah,
he would seems uncontrolled to the extent you risk narrowing down your cava. I mean, I would be scared to do something like that.
चलो सफेद है ठीक है ये भी सफेद है लोअर बॉल
It's just like a small cuff. It's not. You're not going even to the middle of the circumference of the cava.
आप यहाँ
just
का
a little
बंद
cuff
कर
of
सकते
the
हो
cava. So that's what he described.
Live telecast बंद कर सकते हो.
I have not used it.
Right lumbar vein anatomy is so unpredictable. Sometimes it rises from above, sometimes from below. The angle, everything is very unpredictable on the right side.
That's all the more reason that we should insist from our radiologists to give us excellent venous reconstruction. And I often see this lacking, especially on our online forums. People share their experiences with donors, and they want an opinion. They show it, and you usually have a good arterial reconstruction. Often you don't have a good venous reconstruction, so there's really something you should focus on.
Yeah, I really obsess about that. I want to know the location of every little vein, even if whatever lumbar 1, 2. I want to see where it is, and I really insist for that information.
And because when you have a dilemma for selecting the size of your donor, often if you've got complex anatomy on the left, you're wondering whether you should go on the right. Often it's the configuration of the right renal vein that can be the deciding factor. A very short vein might really dissuade you from doing that. Whereas if the right vein is, as Professor Anish Srivastava was saying, if the right vein is quite long, which it often is, it would be quite safe and simple to go on the right side. So, you just have to balance the complexity on each side, and the length of the right renal vein is a major decider of what the right-sided difficulty would be.
You are live. Hello? Hello?
I normally forget that we're sitting up here. Forget to change the...
So as we move on towards the recipient's demonstration, I'd like to thank Dr. Rajiv, Dr. Jha and Dr. Priyadarshi Ranjan. And I'd like to call the next set of chairpersons, please. Dr. Bishwajit Nanda, Dr. Anish Srivastav sir, and Dr. H.S. Bhatiyal sir, if you could please join us on stage, please. Chair.
Deep just a hold.
There is one very small question. When you make an incision for retrieval of the graft, in which patient you will like to make only phalansteal, and where you will select the midline, where will you select the muscle cutting?
Retrieval. So you are talking about the retrieval on the left side.
Yeah, retrieval of the graft.
Yeah, retrieval of the graft. So I think the different surgeons, they prefer different techniques. Initially in SCPGI we were joining the upper two ports, the lateral port and the upper one, means the subcostal.
That will become muscle cutting.
Yeah, so that used to be muscle cutting. And the advantage was that, you know, the kidney was lying just in front of you and you could just pick it up. And most of the times you don't need to put the entire hand inside. Then we started doing fan steel because of the cosmetic, obviously because of the cosmetic reasons. And that could be muscle splitting as well. So that's what they say, the difference is muscle cutting is usually more painful. So there were two advantages. One, that it was cosmetically better, being an iliac fossa incision. And number two, it was muscle splitting. So the only thing is you need to put your hand inside, but I think that doesn't make overall difference in the size of the incision. And we actually published this also in I think one of the journals, kind of prospective comparison, and these were our two conclusions. Only thing is one has to make sure that the bladder is not full before you give the incision, because sometimes your Foley's may not be, generally it is raining, but if it is not, then you can likely cause a puncture or something in the bladder. So bladder should be empty, and these are the two.
I think that's a very, very pertinent and very intelligent answers for all these approaches. Well, it all depends upon one getting used to it. We routinely retrieve our grafts through the fenestrial incision. We haven't had any problem, but on few occasions we had to resort to muscle cutting, particularly so when the donor is a little heavy, so it becomes very difficult. So it all depends on what kind of patient is that, and what is easy for you without any problems. So let's go over to the recipient OT. Who is operating there now?
Good morning, sir. This is Ruchir Maheshwari.
Okay. So Ruchir,
good morning, Anish sir.
Yeah.
So with my team, there is Dr. Sujata is the anesthesia side, brother Suresh and sister Anjali. Dr. Brajmohan is assisting me, and then we have got the audiovisual fellows behind the camera.
Okay.
So we prepared the bed.
Yeah. Yeah.
So he is a 47-year-old gentleman. We are planning for external iliac artery.
Ruchi, there is a question.
Yeah.
Dr. PV Singh is asking that you have already opened up the bladder mucosa.
Yes, sir.
And you know, when you put the ureter on after vascular anastomosis,
yes, sir,
there could be some points this side or that side. So why not open up the mucosa after you have anastomosed the what do you call the vessels, and you have roughly put the ureter onto the bladder to see as to where you really want to anastomose, how long tunnel you want to have. Can you tell us the advantage of opening up the mucosa beforehand?
Sir, mostly...
Or it was opened accidentally?
Open accidentally? No.
Okay.
So, our donor nephrectomy is almost standardized. We cut the ureter near the crossing. So, we get a good length of ureter. And if there is any redundant ureter, we cut it after assessing where we have opened the mucosa.
In fact, Ruchir,
yes, sir,
opening the bladder would always be a very dangerous step beforehand, because before your vascular anastomosis, you never know the culture of the urine which is present in the bladder. Many times these patients are anuric. So you don't know what is the flora and fauna inside the bladder. So I would always resist opening up the bladder and spilling over that betadine solution over the anastomotic area. So it should be done at the last once you have done your vascular anastomosis.
I think yesterday Dr. Anant also did the same thing. He did not open up the mucosa.
Yeah.
And he mentioned about these facts, not about the infection and all. Yeah. But he said, okay, we'll. Somebody asked him why this is such a long tunnel we are creating, and he gave a very valid answer that we're just making it. That doesn't mean that we'll use such a long tunnel. We'll see as to where the ureter lies, and we'll anastomose there, and the rest of the things can be taken care of. So I think that was a very...
Sir, in robotic we practice this thing only, but in open we open it, we get
open means to dissect the bladder and making a tunnel is a hardly 5-minute job.
Okay, fine. Ruchir, can we go ahead? Where are you at the moment?
Sir, can you show me the fossa? So here you got this vein.
Yeah.
The artery. So I have almost left all of the lymphatics along the artery.
Okay.
I have put a tucking suture with the periarterial fascia and the muscle here to retract it. So it will help me during the venous anastomosis. Okay. And once it's done, I'll remove it.
Just a minute. When you will do the arterial anastomosis, you will take off this suture.
Yeah, I'll take out before I start with the arterial anastomosis.
But then suppose the lymphatics are left over around the this thing, external iliac artery. How will you go around the artery?
Sir, I have created two spaces, one proximally, one distally. So if you can appreciate, there is one space here.
Okay.
I have put a right angle across it.
Okay.
And there is one space here, just below the bifurcation. And this area I have cleaned anteriorly, where I am planning to do anastomosis. It should fall somewhere here.
Okay.
I'll assess it finally. So this area I have cleared. Rest all the lymphatics around the lateral border, posterior to the artery, they are all intact.
Well, there's a small question which may not be very sensible to the people around. Sometimes there can be a small little aberrant vessel somewhere, and above and below where you're clamped. And if you're not mobilized the artery, so you can have little problems.
Sir, we find what I have observed, if we got a small venous twig around there when you're mobilizing the vein, most likely we are going to find one arterial twig also. So we dissect a little bit around there and we clip that artery. But yeah, sometimes this problem does happen. So at that time we just mobilize and clip that artery.
But Ruchir, is it your usual practice to put a tacking suture to the muscle? Is it really important, or is it a mandatory step, or you follow it in all your patients?
No, sir. It just gives me a little bit comfort that the vein is clearly visualized at that time and saves an hand of assistant.
See, apart from causing spasm in the external iliac artery, number two, if the stitch is too tight, it might compromise the limb also for in a patient who is borderline ischemic. And
I'll just put a tacking suture, not very tight, so just retracts the artery, nothing more.
Why don't you use a sling, small vascular sling, and retract the artery rather than a fixed suture?
It occupies space. A little bit of suture does not any harm.
I will just ask my friend Dr. Anish. Even when we do open and we have to do external iliac anastomosis, would you like to just make a rent above and below to put the clamps and do not mobilize the external artery where you have to put the where you have to do the anastomosis?
Right. The way Ruchir is showing, I think again, as I said, these are very like individual variations. Okay. But most of us would actually would mobilize completely, maybe about 5 or 6 centimeter segment, because we already know with experience that most of the times this is the place where the artery is going to fall. So that area, and the point is that we should not do a very extensive mobilization. That is the only idea, because the more you do dissection along the external iliac artery, all the lymphatics, they lie there, then the incidence of lymphoria or maybe leaving some of the lymphatics unattended that might cause post-operative prolonged lymphatic drainage and other problems.
Hello?
So, but Ruchir is going
Hello,
on the other side. I mean, he is very conservative and he is trying to disturb the lymphatics to a very minimal extent. That is how I put. But I think most of us are mobilizing at least 5 or 6 centimeter segment.
Hello, Anisha. Good morning. Samit from OT.
Hello, Samit. How are you?
Sir, namaskar, sir. Welcome, sir. We are ready with the extraperitoneal robotic recipient.
Okay.
Bed, we will be just starting to make the bed. We have just put in ports, so I would, if you're okay, I would like to show you how we have placed the ports.
Yes.
Yeah, we'd love to see that.
Please go ahead.
So we have made a fen and steel incision here where you can see the Alexis port. A small 7 centimeter fen and steel incision, and with finger first you beneath the rectus muscle you sweep the peritoneum away, and then with using PDB balloon, they can show you that we used to use for retroperitoneal surgeries to make space.
Yeah, we can appreciate.
As you know, we make space all around.
That's right.
And then first port in the at the umbilicus is placed under finger guidance through this Alexis, which we have made space with. So you put a hand in it like this, and with under finger guidance you put the first port in.
Right.
And then you place the 2 lateral ports. Once 3 ports are in, we dock the robot and sweep the peritoneum laterally to put 2 more ports laterally. All are 4 finger beds away from each other. So we have 5 ports now. One central one around umbilicus is the camera port. To the right of it, monopolar scissor, left is bipolar. The extreme left is the pro-grasp, and the extreme right is the assistant port 12 mm, as you can see.
Okay. So how far apart are these? The palm breadth apart or more?
Yeah. They are 4 finger breadths apart. That roughly comes to 7 to 8 centimeters.
7 to 8.
Usually, when we do transperitoneal, we have more space, so they are a little further apart. Especially the left side, you can see the left side is slightly towards more medial and lower down.
Right.
Rather than the right one, because of the space constraint that we have. So all the ports from the inside will come just at the periphery of the inner portion of the Alexis port.
Okay.
So now we will close the Alexis port, create pneumo, extraperitoneum, and then you will be able to see, we'll dock the robot and you'll be able to see the start of dissection inside extraperitoneally.
Okay, great. Please.
If you have any questions, I'd be happy to answer.
Anybody having any
Samit, there's a 16 gauge Venflon also by the side of one of the ports. What is the purpose of that?
Two things, sir. First, when we have seen that when the pneumo extraperitoneum is for longer time, the air, the CO2 seeps in and causes us trouble later in the part. No matter, even if we don't breach the peritoneum. Or sometimes a very small breach in peritoneum which cannot be identified. So we put this just subhepatic for the gases to escape so that the CO2 does not push the peritoneum at the end of the procedure when we are doing the vascular anastomosis or ureterics.
Okay.
So we have seen that even if the peritoneum is not breached, at the end of so if you have a small rent while putting in the ports, you are very close to the peritoneum and a small amount of gas seeps in, that also will take care of it.
And Samit, now that you have been doing intraperitoneal and now you have been doing extraperitoneal also, so what do you find between the two, which one is more comfortable, which one is more advantageous?
Sir, definitely intraperitoneal, because of lot of space is there and we have done more than 450, we are more comfortable doing intraperitoneal. Extra, we have just started, we have done 10 cases, this is the 11th one, and definitely there is space constraint, especially when the kidney is turgid after you remove the clamps. So it is difficult to manipulate the kidney and do too many maneuvers. So the margin of error is lesser in extraperitoneal rather than intra. So if we talk about comfort, I would be more comfortable doing intra rather than extra.
So then why did you...
Yeah, what is the
No,
real
it is
advantage?
good
The only criticism of intraperitoneal robotic transplant was this only, that it is an intraperitoneal procedure, there is chance of bowel injury, there is always ileus, a bit of it. The pain is more because the pneumoperitoneum is there because of the stretching. So we thought that we might as well go extraperitoneal and see whether we can have the similar results to intraperitoneal, so we can adopt this on a long-term basis.
Right.
So that is the reason.
Yeah, actually the advantages and disadvantages are the same as the debate has been going on for a long time, you know. People doing the retroperitoneal nephrectomies versus transperitoneal. So it's the
yeah, it's the same, sir.
Everything else is same.
So you keep on seeing me. Dr. Anand wants to have a word, sir.
So connect.
Okay.
Hello.
Hello, Dr. Anand, good morning.
We are ready to remove the kidney. So you can see that the ureter is cut and it's making urine. I can, if you like to see, I can show you this way. Probably. You will see that once the peristalsis comes, the urine will start dropping. So we are also ready to remove the kidney robotically, and ureter is cut because we will take time to prepare this kidney while the Samit is getting ready. Now you can see that urine is coming.
Yeah, we can see the spurt.
So what we are going to do now, we are going to remove first the same way as we do it. Incision is already made, and इधर आ इसको नीचे अभी ये नहीं काटा है ना ये काटना है देखो okay, just wait a minute. I think some more dissection is to be done. इसको क्लिप करना पड़ेगा. It's quite thick. क्लिप कर दो इसको. This is probably some lymphatic or something. एक इधर लगाओ एक और.
Initially, the surgery looked so difficult. After sir took over, it became so simple, smooth glide.
So this is our second robotic donor. One was the horseshoe, and this one was the. So everything is done exactly the same way, but now we are ready. And as you have seen that we have not gone intragerota, and only origin of the vessels were dissected. ये फोन कोई देख. Now Deepak, you can bring the, let me just do one more round of, yeah, so you have enough space to apply, just apply. So that is the disadvantage of robotic surgery, because clips are applied by the assistant, but we had a very experienced and good assistant, Deepak, and he is very good. So we rely on him and always
I
leave
think
some
that
tissue.
is very important, most important step, and you should really have somebody very reliable at this stage.
Chalo, just put that in a vein. इसको पहले एक मिनट let me go around it. हाँ इधर आओ लगाओ रुक जा I'll give you. Yeah, now we go and put it. ज़्यादा पीछे नहीं जाओ, हाँ यही लगा दे. Don't worry about the length. Don't go too deep. You don't know what you're catching. Yeah, just stay there. No, just above it. Yeah. No, just take the another one.
You have to see the other end of the clip. It is very difficult.
Just underneath his aorta. You just don't have to go very deep. Just cover the vein.
वहाँ पे काफी टिश्यू भी है बीच में.
Yeah, apply. Good. Just hold this part. Yes.
This is the nightmarish part of the robotic surgery, sir. Yes. Be it nephrectomy, be it whatsoever. When someone else applies clips.
Okay, bring a lymphat with this Himulac. First do the suction. First, okay. Okay. In laparoscopic, I keep suction in my left hand, so I keep sucking it. Okay, put one Himulac clip here. This is the lymphatic. So that these are our modification. We don't take the lymphatics. Just put it here. In laparoscopy, all thing I can do it with my left hand. Here I have to wait to Deepak, but I know he will apply it properly, no problem.
Sir, there is one question. Do you have robotic clip applicator with you, or you are not using it for?
Yeah, we don't have. Okay. We have the robotic staplers, but not the clip applicator. We did not ask for it, and we don't need it.
But what do you advise?
Sir, robotic clip
always to depend on your somebody else or
Himulac clip. Yeah, if you have a good person, then Deepak is very good. We don't allow him, otherwise he
can. Sir, robotic clip, VEC clip applicator is also available, and probably better than asking assistant to apply VEC clip. It's better to apply yourself. It has got angle at 90 degree. Yes, you could place it nicely.
They are available, yes.
एक यहाँ लगाओ. One Himulac clip here. Yeah, you can, but I think everything will add to the cost. I think it is all done now. So my fellow Amit will put the hand and take it out. Remove the Caesar and remove this fourth arm. And Amit, you can put your hand and take the kidney, catch the lower.
Can we go to OT8 to Dr. Ruchir as to what is he doing now at the moment?
Okay, just okay, don't worry.
Dr. Ruchir?
OT8 connect. OT3 connect.
Hello.
Hello.
Dr. Ruchir.
Yes, sir. Sir, almost completed the bench work.
We are not able to see the images from OT8.
Sir, I am in OT3.
OT3, sir.
Okay, sorry, OT3.
So, we have almost completed the bench work. We got a single renal artery and single renal vein. Both looks okay to me. The adrenal stump is very near to the margin, so I'll assess how to do it. And this is lumbar vein, I am going to tie it.
Okay.
And this is the ureter and gonadal vein. This is the important tissue we are preserving. We are not touching anything between this gonadal triangle.
Are you taking off the gonadal vein or are you leaving it behind?
Gonadal vein, it's here. I have just sacrificed a little bit apart. Rest it's along the ureter. At this point, we usually keep the kidney covered in ice all around. So I have opened it for the demonstration purpose only. So you can appreciate this is the hilar tissue. And the whole fat around the ureter and adventitial tissue has been preserved. And I have tied all this perihilar fat to ensure that I get minimal amount of bleeding once I open the clap.
Can we go to Dr. Sumit Soti where he is doing extraperitoneal dissection? Robotic extraperitoneal. Yeah, it's here.
Hello, Anish sir.
Hello.
Haji sir.
Can you just show us what dissection you have done? And
Yes, sir. Once your ports are in, you should first identify the bladder, and from the lateral surface you come on to the iliac vessels. The one landmark that you can see is the inferior epigastric artery going up, or you will see vas in males and round ligament in females going across the iliac vessels. So you need to identify it, and along its border you can see the peritoneal fold going in. So you start retracting the peritoneal fold medially over the vessel like I have done. This is the round ligament and these are the vessels.
Right, okay.
And we have enough length of vessel, I think. You can do more if you feel the need. Taking care of that. This is the peritoneum, so not to open that. And once you do that, you can start off dissecting the vessels.
Where is the inferior epigastric artery?
It will go like
here,
this from here, sir.
Okay.
Yes, this, you can see the fold here.
Right.
This is it.
So it is always good to take all these lymphatics more laterally.
Yes, sir. You try and do that if it is possible. And what if we think that they'll come in the way, we'll clip them here and here to minimize the lymph leak later.
Sir, one question about the external iliac artery dissection. So if the lymph node packet is not that thick, we can lift the mobilize and lift the external iliac artery along with the lymph nodes, and we can apply bulldog clamps or whatever clamps at the start and the bottom along with the lymph nodes, and we'll just dissect a part of the area on which we'll anastomose. We'll do not have to make a jacket or anything, and we'll not disturb the lymph node packet at all.
I think that is also one of the ways. Yeah. The idea is that the minimal dissection and clipping, good clipping of the
It takes around
lymphatics.
2 to 3 minutes to lift up along with the whole lymph node packet.
Right.
The distal end creates a problem proximally. Usually there is not too much of lymph nodes, lymphatic tissue. You can apply the bulldog over the lymphatic tissue actually.
Along with including the lymphatic tissue and
the external iliac artery. It holds good. Yes.
It depends. In our patients, they are very, sometimes very densely adherent also. So sometimes if you do a little bit of dissection, sometimes you feel as if the adventitia is getting torn. So that's why people, they take it along with the lymphatic and then gently separate. So
and you must remember this patient is the recipient of the patient that underwent robotic donor just now. You could see the lymphatics in that donor.
Okay, so it's a robotic versus robotic, both.
Total robotic.
Total robotic.
Dr. Shamit,
sir,
what would you count as actual advantage of doing extraperitoneal over otherwise what you're doing transperitoneal robotic transplant overall?
Just you can claim to mimic the open approach exactly.
Same thing, Aditya. Before you came, we discussed this point.
Yeah.
And so, in brief, what he is trying to say that the arguments are the same as for the retroperitoneal nephrectomies, simple nephrectomy or radical. Same way, that means the ileus is less, injury to the surrounding organs, like if we say for the nephrectomies, liver, spleen need not be disturbed. Then the chances of incisional hernia also are, although it is only 2 to 5% because you don't open the peritoneum. And then the pain which they say because of the intraperitoneal gas inflation, the shoulder pain and all. So I think those are the more or less same advantages here.
And I think very intelligent, very short answer which Samit said, that this is the exact replication of the open surgery which you do. And if you can get good experience in this particular approach, so it will be the similar manner as we do normally open recipient.
That's why nephrectomies also were always historically were being done retroperitoneally. Only after the laparoscopy came in for our own convenience, and we changed over to the transperitoneal approach.
When I asked that question to Dr. Samit, I knew the retroperitoneal man is sitting here. So he will tell us all the, advantages, disadvantages of all these approaches. Yes, Aditya?
Sir, as such extraperitoneal approach which we do in open transplant, it in itself is very less, having less impact on the patient, because we are not making patient Trendelenburg. And in transperitoneal transplant, I think we are making extreme Trendelenburg.
Yeah.
Maybe that is not needed in extraperitoneal. In lap radical prostate, which I do extraperitoneally, I find next day patient is as comfortable as a patient of TURP or HOLEP you do. They would hardly feel anything has been done, and ileus is last thing, of course, we think about in those cases.
Yeah, in general your observation is correct, because I have also done a very huge number of retroperitoneal nephrectomies and all these things, as Dr. Bhatia was. So the outcome on the next day morning is very different between the transperitoneal and the retroperitoneal approach. I think one of the things is scientifically or on evidence base, it is the ileus and other things. Why the overall morbidity is also less, I think it is there, the observation is there, but how to explain that is probably little different. So.
One major measurable factor is the comfort of anesthetist when you don't make patient extreme Trendelenburg. There is a drastic difference if the surgery, any surgery goes beyond 2-3 hours. They will say CO2 is getting built up, you need to straighten the table. Many times they ask in transperitoneal lap and robotic prostate also, if it is going for long. But in extraperitoneal, hardly we have to bother about. We don't even wait for bowel movement to come. We send the patient next 36 hours, but it will eventually come anyway.
No, sir, that way, can you hear me?
Yeah.
That way our anesthetists are great. Never complains. Always supportive.
I personally feel that the advantages which are given to the patient as a transplant patient should not be underweighed by other things. You must realize that the ultimate goal is that the outcome of the transplanted kidney should be there. So one should keep it in mind, that is of the prime importance as compared to all other factors. All other factors can be negated in front of if graft not functioning well, because we wanted to do that particular procedure. So over the years, when things crystallize down to what are the advantages and disadvantages, so all the things should be weighed in the advantages to the recipient.
Correct, sir.
And the outcome.
Well said.
Dr. Shamit, in transperitoneal, I can understand you are bearing the artery so much because you have to raise the flap. In this case, do we really need to skeletonize artery so much?
See, sometimes small tweaks from these artery external come to the lymphatics, and if you don't clip it, it will keep spoiling your field. So till now we have done that. Probably it's a good suggestion. We can try and do away with it. When we do extraperitoneal, we also need to make little space for the kidney to fall. It's not that you don't need to make any space, otherwise the kidney will be difficult to maneuver. You need to keep the kidney here in this fossa. Here.
Yeah, this is a nice fossa made, a nice dissection. Besides the fossa, I think you have carried out the arterial and the venous dissection very meticulously. And we could
the lymphatic leash we have left.
Yeah.
And now we can go with the bladder.
And you have left the peritoneal fold with
the bloodier than what it is in transperitoneal because of the space that we try and create. You tear apart the small vessels, and by the time you are in and pneumo takes effect, there is some little bit of oozing going on here in extraperitoneal, which you don't see in intraperitoneal. It's very clean intraperitoneally.
I think it is equally clean. Samit, did you hear the comment?
Sir?
I said it is equally clean.
Thank you, sir. But it is slightly, towards the red spectrum than we usually want our fields to be.
No, the type of tissue certainly differ, intraperitoneal is a different ball game and extraperitoneal is different.
Different, yes.
Is the bladder distended now?
They are doing it, sir. Please distend the bladder. Bladder fill karna, please.
Dr. Shamit, you have left the peritoneal fold along the cord intentionally because it will give you more space. Like we do in a hernia surgery, we completely
No, I am waiting
take
for
the
Dr.
peritoneum
Anand to
down.
come. What he does in females most of the time, he will cut this after coagulating or clipping the round ligament so that he can have more space. But
Other side, on the right side.
What we do with VAS or with this is you can keep on dissecting close to this. This is the peritoneum going in. You can see the fold?
Yes. Yes.
And along with this, if you keep on dissecting, you can free it till here. So you can have more space.
No, that is the VAS, the other side, where the other peritoneal fold is there along the cord.
Yeah, we don't need to do anything much here.
No, right side, lateral to the vessel.
So here we don't free the bladder much or drop the peritoneum. We only need a port to come in, and that's it. So here you can see the bladder. The kidney will be here. Ureter will come from here to here. So this is the way we will make the tunnel here.
And you know, there are a lot of difference because you don't have to drop the bladder. It's just in front of you.
Yeah, it's just in front of you, right, sir?
So this dissection is basically to just making a space around the.
Yeah, we will make a small detrusor tunnel to.
Detrusor tunnel, okay.
You can see the.
To make it make it an anti-refluxing.
Okay.
So this is the fat perivesicle which you need to free first, and here you can see the bladder muscle.
Right.
How would you manage if during dissection the peritoneum gets nicked or there is some leak into the peritoneal cavity?
You can either clip or use a Weichel 3/0 suture to repair it. Most of the time, very small leakages, they will not bother you until you do a lot of suction. But once you start sucking and there is a hole, the peritoneum will rush into your field and cause trouble. एक बार क्लीन कर लोगे प्लीज.
I think Dr. Rucher is still carrying on with the bench preparation of the kidney. Okay, is it for this kidney? Can we see what Rucher is doing? Can we go over to the other OT, please?
Dr. Ruchir.
Hello.
Dr. Ruchir.
Hello.
OT3 on.
So I have started with venous anastomosis.
Okay.
I placed the sutures. Now I am tying the upper corner.
Are you using proline?
Yes, sir.
Why? Because yesterday Dr. Anand was using the other suture.
In robot, we are using Dacron. In open, it's proline.
Robotic is.
You're doing open. He's doing open. Okay.
Sorry. Samit is going to do the robotic. There he will use the
Sorry, I thought...
The only difference is that I am a left-handed surgeon, so my movements and my steps are a little bit different.
No, left-handed movements are always admirable, you know. I am a golfer, so lefty golfers do very well.
Sir, it was during the initial phase when I was learning, I had to translate every movement. So that was a bit difficult, but now it's okay.
Fine.
So whenever you are comfortable, we like to see the lie and...
Ruchir, if the camera can be focused...
Yeah, whenever you are comfortable.
Vessel.
Yeah. So
you are using a Satinsky clamp or a Bulldog clamp for the vein?
It's Oshner.
This is a modified Satinsky.
Yeah. So it's a single clamp which goes up and down.
Yeah.
And while decumbering, we need to remove only one clamp.
And it sits on to the vein very, you know, admirably.
Yeah, the advantage is, supposing there's an internal iliac vein which is going just below, sometimes the branching is more distal.
Yeah.
So we need not clamp it or tie it, it just covers it.
Yeah. We can see both the OTs, PIP of the other OT, one side robotic recipient, other side open recipient. We can see, we can appreciate the robotic arms of Dr. Ruchir, and we can see the actual robotic arms being manipulated by Dr. Samit. So, one side they are human robotic arms, and the other side they are mechanical robotic arms, and one can really appreciate the difference in the manipulations and how you maneuver.
So Ruchir, you don't tie the internal iliac vein. Suppose
no,
you
sir.
don't.
Ruchir, tell me one thing. There are many people who talk about this internal iliac vein that we never ever, even Anand Kumar says, I never ever, tie the internal iliac vein. But I have seen over these years, I don't know how my friend professor is sitting next to me, who has had a very large experience, and we also had a very large experience, that at times, if it is possible to ligate the internal iliac vein and get the vein up, it is advantageous. Am I right?
No, actually I also
I agree with you.
tie the internal iliac vein because we are using two bulldogs. When this Satinsky is being applied, so that was my question to Ruchir also, that you need a longer segment of vein.
Yeah.
Because the Satinsky has to go and sit in comfortably. So that's where I have seen those who are using Satinsky, they are generally tying the internal iliac vein, so that external iliac vein is nicely, it can be lifted and a Satinsky can be applied comfortably. But when we are applying two bulldogs, then we don't need to tie internal iliac vein in 95% of it.
Yeah, I agree with you, but I have a little submission. It is not that these particular clamps, actually we started these clamps long time back. There used to be a person known as Johnson from Kerala, whom I told to make a Satinsky modified, which can sit in the pelvis very well, and normal Satinsky clamp will stand up like this. Yes. So they have modified that. It is very nice clamp. Oshner clamp. It is a modified this clamp, and it sits in the pelvis very well. I won't say that by applying two bulldog clamps you don't ever need to tackle the internal iliac vein. There are situations when the fossa is very deep and you are finding it very difficult, and if you can, don't struggle to ligate the internal iliac, because if it slips, there can be a horror. So be very careful, and if you have adequate length for double ligation, you ligate it, the vein will come in front of you, it makes your life very easy without any sort of added morbidity to the patient if you take due care.
Yes, sir. In fact, one more advantage which I find with two bulldog clamps is that when I'm releasing the clamp, I can control which clamp to release. So if I'm releasing the clamp from the upper side, from where the venous return is not coming, if there is any one or two bleeder, you can easily do, and then open the distal clamp from where the blood flow is coming. So that is a major advantage.
I think this is a surgeon preference. Just like sir uses two clamps, I also use two clamps. Both sides, and sometimes when it depends on the position of the internal iliac vein, whether you want to tie it or do not want to tie it, depending on the mobilization of the vein. Sometimes, rarely, you have to tie it also.
Should I pass a small comment? As they say, too many cooks spoil the broth. In the similar manner, too many instruments inside can give you a bother.
The two bulldogs usually do not actually.
Sir, the other advantage of tying the internal iliac vein is when the vein is very deep. Many times muscles are strong, the artery is quite up, and you want after the anastomosis vein to little come up so that the arterial anastomosis is easy. Sometimes artery may be short. So when that is the time when you need mobility of the external iliac vein. So once you tie it, it comes up easily. In a thin patient, it may not matter, but in an obese patient, I have found very useful.
Well, I will give you one. Professor Dhawan, who was the pioneer of transplantation in All Institute of Medical Sciences after CMC started. I had the occasion of working with him, and whenever there was a problem in the internal iliac tying towards the common iliac, he would put the clamps, nicely suture it with the proline and carry on. So there are different ways and means. It all depends upon the surgeon, the comfort of the surgeon, and the advantages given to the patient, situation, anatomical situation, how you tackle those problems. So I think one has to, over the years when you grow, you have to find out the pros and cons, and do not go with that fixed idea. Look here, I will never mobilize the internal iliac, or I will always mobilize the internal iliac. So as the situation demands, a surgeon always goes according to the situation which is there. A soldier fights in the war by seeing the conditions, how to save him, his territory, and how to kill the animal.
So one more.
Ruchir sir, have you started suturing, or you are taking a parachuting suture?
No, I have started suturing the vein.
Okay, it's not.
No, this is the other side. This is the other side now.
The first side.
Okay.
The first.
He is a left-hander.
So one more advantage of two bulldogs I find is that they allow the vein to be filled adequately. You can inspect the inside of the vein. Sometimes they are the valves which you might want to excise. Or when you fill the vein before putting the last suture, the vein fills up adequately. With this kind of clamp, it may not allow the vein to distend completely.
Yes.
So
I agree. So, as I said, those who do put this Ochsner or Setinsky, they need a longer length of external iliac vein. They need to tie internal iliac in most of the circumstances. Whereas with two bulldogs, as I said in my practice also, 95% I don't tie the internal iliac. And the advantage is, as Ranjan is, I mean, he has already highlighted that one thing is you can open the clamp or the cephalic clamp and then see. And even before that, actually, we don't need to see. When you do the anastomosis, you fill the vein. Absolutely everything is clear. And in fact, if there is a leak going on, you may take few more minutes and you can correct it also. Because we are doing the vein first. So the kidney can be flipped here and there.
That venous distension with the hepatitis line is very important.
Very important. So that thing is little lacking here.
Sir, with two bulldogs, the vein is so mobile. You can flip flop, do it as this becomes fixed.
Well, I think the audience, the youngsters, should not go away with this kind of things. You know, everything should be available in your hand. Whatever you feel is good for you and good for the patient, you must do that thing. So one should be accustomed to every type of maneuvers which are required just to give the best to the patient. Yes,
sir. Bulldog also has a fixed strength. Many times vein may be flimsy, so there the Setinsky clamp you can control how much compression you are giving. The bulldog are usually with a fixed compression. Does it have any impact using a bulldog versus Setinsky?
No, I don't.
I remember yesterday's comment. We got into the loops very badly, and now we are getting into the bulldogs very badly. Let's go ahead and see as to what's happening in the OT there.
So bulldogs are calibrated. If you buy the bulldog from a good company such as Scanlan or Askilab, they are calibrated bulldogs. Even some Indian companies also calibrate, so you can gauge the pressure. So most of the times, if you buy a calibrated bulldog, it is going to be fine.
So otherwise, the clamps are also there, no venous clamps. So they are calibrated. Many of us are applying venous clamps. So, and absolutely, we have never seen, venous thrombosis because of that, because they are calibrated, they are tailor-made. So, venous clamps also, they help a lot.
Ajay, you are sitting very quietly, I thought we must listen something from your side also. Yes. You're very in a pensive mood. Why?
No, not at all, sir. Can we see what Ruchir is seeing?
I think that's what...
What Ruchir is seeing, we can't see.
I think there's some problem in the camera angle.
Okay, you go on comfortably.
Ruchir, I want to ask you one thing. This is for my friends sitting here in the audience. Do you start do you put two sutures on both the corners and then start off? And there are some people who will put a suture in the center so that both the walls can be lifted up and the suturing can be easier. So what is your preferred way of suturing the vein? Particularly so when you're using the right side with the IVC cuff. It's very long anastomosis.
So I am from the lateral one. I take two corner sutures and two in the mid to retract the vein.
So he has taken stage sutures.
So we couldn't see that, because if the cameraman can show it to our friends sitting here, it makes a difference.
So just let me tie this knot and I'll try to make it visible to everyone. कितने पॉइंट डाल दिया?
So I also use the same technique, two sutures at the ends and two stay sutures. It makes it very comfortable.
I don't know, for ages together, I have never used that type of technique for the last 30 years. We never had any problem. However, when we start on the other side, my assistant gives a little tug, and you find it serves the same purpose after first two sutures. It serves the same purpose of getting two layers together and being pulled away from the main vein. I don't think it really matters, but yes, as I tell to all my friends, one should get used to every kind of maneuver, whichever he feels is comfortable, whichever he feels gives him the best results, and one should not be dogmatic. Okay, I will do this in every case.
Yeah.
Wherever you find you want to use that, use that. Wherever you want to do not want to use that, don't use that.
In fact, your dependence on the assistants goes down when you use a stay suture. Very much.
Exactly.
You're not dependent on the
just leave it.
So is it visible now? No.
No.
So table को side tilt कर दीजिए please. Table towards me.
One knot at the end.
This is the
one
lateral
stitch,
suture,
one
the
knot
middle
at
one.
the end. That makes me more comfortable.
Yeah. Yeah, it's the comfort of the surgeon and whatever you can give.
Table इधर कर दो ना. कहाँ है?
There was a very nice comment yesterday. Somebody was telling the patient was in lethargic position and the patient fell down. The patient fell in his lap. I did not know where the graft fell. So, as Richard is telling, turn towards me, you should be a little careful that the turn should not be that much.
Generally, they tie the patient.
Sir, it's the way I learned from Dr. Anish. He always tells the name, table towards Ruche, table towards myself, or table. So, no left or right, so nobody is confused.
I just want to see one thing. I have never, I don't know about Aditya Pradhan, I have never wrapped around the kidney with the gauze piece like this in the open surgery, because if the gauze piece is not there, I think you get more space to see and to show in the conferences rather than, because it is occupying a lot of space around the kidney. It doesn't really do any advantage.
No, but when you you're continuously putting some cold saline and all, so
even that is not required. Even that is not required these days. I have left it for the last couple of years. When a chap used to be standing with a syringe with a cold saline and pouring on that thing, we hardly ever do that, and nothing happens. Am I right, Ajay?
Yeah, absolutely right, sir.
Nothing happens.
Some ice slush on the psoas muscle and one ice pack in front of the kidney. That's all. No continuous pouring. Actually, that floods your fossa, and someone has to keep on sucking it out.
So having a gauze piece serves two purposes for me. Number one, you can tailor the ostium which you make at the hilum, so that prevents the fat which is hilar overhanging at the time of anastomosis.
Exactly.
That is a one big advantage. The other advantage is that you can put two Alice forceps, just tuck the kidney and it gets fixed very easily. So it makes it more comfortable.
This is what I tell, that the comfort of the surgeon and the comfort of the patient has to be tailored as per the requirements.
Yeah.
So it's not that one should advocate that you should always put this thing. So there are ways and means, there are other ways and means of doing it, and one should get adapted to these things.
And when we are doing the vein, artery is inside the gauze piece.
Yeah.
Once it is done, only you remove the artery.
Yes, yes.
So again, it's the way we are trained, we have been seeing the things, we adapt those things.
No, that's fine, that's fine. No, it's just for discussion. It's not that, there's no criticism.
Yeah, it is all.
It is just a discussion so that, everybody is awake.
Yes, sir. Agreed.
So sometimes they say the chairman is itself sleeping, He's not asking any questions and he's not doing any discussion. Iqbal, what do you say that?
So, for the younger audience, the very important point of
Is
technique
Ruchir using backhand? He is a left-hander surgeon. So, is he doing backhand?
No, sir.
Yeah.
No, he's a left-hander, no?
Left will be forearm, no, sir.
I am using it forehand on my
Forehand.
side.
Forehand.
The left hand's forehand.
Forehand, down to up.
His right hand's backhand. You play tennis?
No, sir.
No.
Sir, it was definitely an advantage while I was
So this is
used to play badminton.
for the right hand. This is for the left hand. So Richard, besides your wonderful expertise in demonstrating the anastomosis, we are having some, good moments here, discussing many other things,
Yes, sir.
What is backhand, what is, straight drive, what is left hand drive.
So it's a dynamic discussion like with the dynamic chairperson.
No, it is not dynamic, is the person who is demonstrating everything. So your dynamism is absolutely on the screen.
So similarly,
Thank you, sir.
like using the kind of needle holder.
Yeah.
So many of us prefer the Casavijo, but he is using the other one. So
He is my friend. He is my real friend because I never use Casavijo.
Is it?
Never in my life.
So आपका बड़ा strict है बस.
So
what suture do you use for artery, sir? What suture? What size of suture?
I was using 6-0 for the vein, and I used to use 7-0 for the artery, but I have switched over to 6-0 for the artery also. But if I find the artery is very fine, then I would use 7-0. So this is what I'm telling, that every surgeon has to cater for the particular situation. Whether you can fire with a pistol or a stain gun, it all depends.
So there's a new needle holder manufactured by Scanlan known as Scan 2. It has a handle which is beautifully like a Castrovijo, but it has a flat handle. Slight curve, flat, and then again. It's a beautiful needle holder. I've switched over to 9 inches that for the past 1 year. Mesmerizing.
All the models have different curvatures.
Scan 2.
And the person has to appreciate every curvature.
Yeah, that curvature suits for me.
Am I right?
Dr. Ranjan,
So instruments
share the photo
in
with
the
us.
hand of a surgeon is what? Like a model.
I will, Ruchir. I
like
will
a model,
send you.
how you take it?
No, sir, you are experiencing it. You're not just taking a photo.
So Richard, you are almost...
I'm done with the vein, I'm tying the final knots.
Yeah. So Richard, when do you really go in for the internal iliac arterial anastomosis end-to-end rather than external iliac?
Sir, if the patient is less than 40 years old, there is no history of diabetes, and on table we find that the artery is supple, there is no plaque, then we can go for internal iliac. One of the advantages when we have got multiple branches, more than 2, so we can take the crow's foot out and reconfigure it on the bench. But this is a 57-year-old, so I didn't even look at the internal iliac in this case.
Good. And you know, it's always good that for a second transplant, one should always use external iliac artery, because if the other surgeon has used internal iliac artery and you use both the internal iliac arteries, there can be problems besides the erectile dysfunction. There can be many other disabilities which can be encountered. But as people say that people, if you use internal iliac, some people have what do you call that? Problem in walking and all those things. We have never come across with that.
So, Ruchir, excellent surgical technique. I really loved how you handled the vein. The one thing that I would do different, is before I take the final suture, I always put a lot of hep saline.
He did that.
He did
I
that.
did it.
Okay.
Yeah. He did that.
So I owe my techniques to my professors and my teachers. So I have removed this suture. Now artery is now free.
Okay.
थोड़ा करना.
Sir, I have...
You can turn the table to the other side now.
Yes, sir, we are doing it.
Sir, this flipping of the kidney makes lot of dependence on your assistance. I have never done this. I keep the kidney on psoas muscle till all the anastomosis are completed. I do not flip the kidney like this while doing the anastomosis.
Sir, we have seen your excellent skills in Aurangabad.
Thank you, Ruchir.
Because you are doing it parachute technique for both, for
yes,
kidney, for vein as well as artery. I have watched you. So when you do parachute technique for both, you can rest the kidney in one position and both can be done. But when we are doing this way, flipping has to be there.
So this is what I'm telling time and again, that the surgeon has to get used to various kinds of manipulations and maneuverability to see that what best can be achieved. Now we discussed a lot, Ruchir, yesterday about using the punch and not using the punch and doing an arteriotomy and this and that. So what is your preferred way of doing an arteriotomy?
I'm a punch man.
You're a punch man. You punch very hard or you punch very soft?
Depending on the artery.
No, because it is very important. If you punch too hard, you might punch the other side also.
No, sir, it should be just adequate.
Good. I think that's a very good comment.
What size of punch are you going to use here? And are you going to spatulate the artery at one of the ends?
Like today, as we got into the discussion of clamps. Yesterday we got into the discussion of spatulation and not spatulating, using a loop and not getting loop. So we got really looped into that. And it was very difficult to unloop, it's just like flying a kite or tumhara wo jud jata dhaga. So with great difficulty, we got out of the loop.
Hello, Patyal sir.
Yes.
Sir, submit this side. I'm in OT12, the robotic donor that we did.
Okay.
We are ready with the bench dissection. We wanted to show you, and especially Dr. Rajiv Sharma, the sock that we make to put the kidney in. Our homemade sock with the 7.5 glove.
Okay.
So please...
show us the socks, man. You can patent it.
So we take a glove. We usually take a green one or a brown one rather than white. Because it does not cause us any light reflection inside when we put the kidney back in. So one end, the distal end, is tied with a big silk suture to close the end off. दिखाओ ऊपर से दिखाओ, पास में आके दिखाओ ना.
पेशेंट के राइट में खड़ा रहेगा और एंड टू एंड पेशेंट के राइट में खड़ा रहने का. और एंड ऑफ रीनल आर्टरी टू एक्स्ट्रा रीनल आर्टरी अगर करने का है तो पेशेंट के लेफ्ट में
and we cut the fingers and then the entry part of the glove, we first put ice in and then put the kidney, ठीक से focus करो. And now put the kidney in. This freshly made ice slush that we use, as you can see. Now the kidney goes in upper pole inside first, and the ureter remains out.
And you put some more ice because
we will, sir.
Because using that gauze piece, you put the ice all around, and using this thing, you have put it only for the lower pole, and for the upper pole,
It is in the upper pole, and then in the lower pole, it will. Once we are done with everything, we will squeeze it properly to evenly distribute the ice slush. And make a small nick here in the glove for the vessels to come out. You can extend it as per your needs, depending upon how wide the vessels are placed or how close together they are. ऐसे करो, slip. उधर भी कर दो थोड़ा सा. So here comes out the vein, as you can see. And on the upper pole side there will be artery. So if you need, you can extend it a little. और थोड़ा सा कम रहेगा. और से बेटर दे दो. नहीं ऊपर की तरफ करो, अभी और ऊपर है आर्टरी. थोड़ा सा बस. And here comes out the artery. You put little more ice in it. नहीं उसको रख दो. बस ज़्यादा नहीं, बहुत ज़्यादा नहीं दीपक. बस ज़्यादा नहीं, जगह नहीं है. Ureter भी है. Ureter भी है इसमें.
Can we go over to Ruchir now for the time being, as he is tying up the...
So one quick point here, Dr. Samit, thank you for demonstrating the sock. But the only two concerns I would raise is, like, here kidney is not able to breathe. If a sock or a gauze, as Ruchir is using, the kidney can actually, this is, yeah. And the second point is the ice is in direct contact with the kidney. I usually tend to avoid that. I wouldn't.
See, when we were using gauze, then also the kidney was in touch with the ice.
Yes.
So it's more.
No, it doesn't make difference.
The advantage of this glove sock is that it helps us to put the kidney through gel port or Alexis pretty easily. You don't need to push. It slides down inside, and it is easier to go in. And when you cut it, it is easier to cut rather than a gauze.
That is true. Yeah.
So we are just experimenting. This is the 11th case that we are going to use this in. So we will do more necessary modifications probably in times to come.
Okay.
This
all
is
the
very
suggestions
nice.
are welcome.
Nice. Okay, Samit, we'll just go over to Ruchir. He's doing arterial anastomosis. Just
Sure,
for the
sir, sure,
sake
sir.
of
Thank
our
you.
younger friends, those who can watch the arterial anastomosis. Ruchir, have you spatulated it or you haven't?
I spatulated it, sir.
Okay, spatulated on the distal end or on the proximal end? I mean, cranial or caudal?
Spatulated on the distal end, that's caudal.
Okay, fine.
What size of punch you have used?
That's a 5 number.
5.
5.
Do you always use one shot, or you sometimes you may have to do 1.5 to 2?
Rarely, yes.
But with 5, even 1 is quite...
Quite enough. No, have you come across with problems using the punch? Because our younger friends may not have the punch everywhere. But have you come across using the punch, and what precaution you must take, and what kind of problem you face with the punch?
So sometimes, if you are not careful, so you can injure the opposite wall, and then it's a real nightmare. So arteriotomy should be just good enough so that the punch can go inside nicely. And
One's little care is that the site of punch, you must remove the sheath on the artery, because sometimes the sheath gets stuck into the punch and the punch doesn't come out. And by a little bit of maneuvering there, the arteriotomy can become bigger, can give rise to problems. So if you just give a small incision and take off the covering of the artery at the particular site where you want to put the punch, it is always good.
yeah, sir, that's very important point that you are saying.
Yeah.
So if this happens, it can give jitters and tremors to the early one. But the only way is to gently cut this adventitia.
Yeah.
So it comes out and just pull the punch handle while supporting the punch.
Yes.
Yeah, so when you take the punch out, you should not be, it should not be jerky movement. It should be very gentle, so that if there is any part stuck,
you can cut it off.
You can cut it with the scissors rather than you pulling it.
So the punch both going in and going out should be very gentle.
Yes, yes. Yeah, if you are gentle, I think you will never hurt the posterior wall. I think it is only when you do it very casually and not making a large enough arteriotomy for the punch to go in easily, only then the posterior wall would get damaged. Or otherwise, why should the posterior wall get damaged? That would be...
So I have taken both the sutures.
The correct technique of punching is you just make a stab hole in the artery. If you move your stab knife too much deep towards the posterior wall of the artery, you can damage it.
Yes,
or if you make see, the function of stab is to only stab. What the commonest mistake done is, you take a stab and go on incising the artery with that. You should avoid doing that. Just make a stab, and the punch can, or artery will accommodate punch in a smaller hole also. And once inside the artery, the sign that punch is adequately inside the artery is you can move the punch like this or like this. And the artery should be stripped off of its all fat and connective tissue, so that punch really punches out a nice hole in the artery.
So, but and when you are about to fire it, you should little pull it up and see that it rests in the inner side of the artery.
Yes. And
going very down.
when you come out, you should see a nice circumferential piece of the artery within the two jaws of the punch, and before firing it the next time, you should your staff should be careful enough to pull that piece of the artery out.
No, but about this making a very small hole and trying to put the punch in, I think, I mean, the ways differ, as we have been talking all this while. If you make a arteriotomy good enough so that your punch can easily go in without any issue between the adventitia and intima.
Hello.
So that is also a
Hello.
good enough technique.
Yes.
So OT to connect. Hello.
Yes.
Yeah, I'm Dr. Anand Kumar. Now we are going to drop the kidney. Just we wanted to show how we drop the kidney.
Okay.
Okay.
What was your question?
With just the punch, if you are using only a stab and then trying to insert the punch, it will take out one side of the wall. It will do a arteriotomy very bad. You have to move your blade a little ahead.
Yeah,
So
that's
that
what we can use pots to stab it and use pot scissor to cut it adequately. Then put the punch. That is safer.
One more modification which I have started, one more little step which I do now is once you incise, do an arteriotomy, I put a tenotomy scissor closed inside so that there is no dissection. Just spread it little and then introduce the punch. Otherwise, directly introducing the punch many a times causes dissection in the interior.
Yes,
internal
that
wall.
is while introducing the punch, that is one place where you might cause a dissection
Okay,
between
Anant,
the adventitia and
we are with you. We are watching as to how you will drop the kidney in.
Okay. So that's the advantage of any hand device.
Yeah.
Like you can place it nicely and immediately the cap is put and you are ready for that.
And then you can put the pressure inside,
Pressure build karo. Okay.
And how much pressure do you keep it there?
Usually 12 centimeter of.
Okay.
If 12 is causing problem, then we go to 15. But most of the time, in transperitoneally, 12 is enough to.
There must be some difference between transperitoneal and retroperitoneal, because transperitoneal is a big cavity.
Yeah, there is enough space.
Whereas
so even if it's 12 centimeter of pneumoperitoneum, there is no problem. कहाँ है हमारा पोर्ट? कहाँ है? नहीं ये दूसरा वाला कहाँ है? अरे एक मिनट, हाँ ये है, ठीक है, अच्छा, ओके. कैसे आया हुआ है यार? हैं? इसको ठीक करो. इसको ठीक करो. और वाला कहाँ है? Okay. This is the round ligament. I'll just sacrifice it. इसमें वो नहीं लगा हुआ है.
Your bipolar not working.
इसमें एनर्जी नहीं लगी. अच्छा. लेते हैं, अभी सीजर लेंगे तब काट देंगे. Where is the vein? चलो वो दो पहले जरा ये लगाओ, जब वो दोगे तब काट देंगे, या पहले सीजर दे दो काट दें इसको। और देख करके डालो जरा ये। अच्छा, ये आप bipolar and give me bulldogs.
Because of pneumopressure, this vein is not looking distended, or patient is underfilled?
Yeah, it is because of the pneumopressure. It looks like that, as if it has already been incised.
No, in this, the difference is the distal clamp is being put first. So, that's why.
No, he was asking about the appearance of the vein right from the beginning.
Okay.
That is because of the pressure.
And in robotic, the position is entirely steep, so.
No, in retroperitoneal, they don't keep so much of steep position. That's what they discussed yesterday. Sometimes if you have a problem, they'll make it. Otherwise, the position is almost supine. We can.
चल बदलो। The technique will be same what I showed yesterday now onward, and this is the same suture we have taken which I showed you yesterday.
हाँ, बहुत लोग करते हैं, हमने भी यूज़ किया, फिर वो बड़ा महंगा पड़ा, फिर हमने बंद कर दिया।
यहाँ तो जरूरी है मेमोरी की वजह से।
हाँ, सेकेंडली ना यहाँ पे अगर वो प्रोलिन टूट जाए तो इट्स अ बिग प्रॉब्लम।
नहीं, इसकी मेमोरी नोट करने के लिए
ये बड़ी अच्छी चीज़ मैंने देखी इसको, जो पहले से दोनों जैसे हम प्रोस्टेट में करते हैं ना, ऐसे दोनों सूजी उसको बांध लेता है। So that you learn these things from each one's experience.
दोनों सूचर को
बांध दिया ना वहाँ पे, there is a knot there, so you don't have to put a knot. It saves time. अभी वहाँ से इधर आएगा ना, दूसरा इधर से आएगा, एक ही knot बनेगा।
पहले ही
हाँ।
Flow back and making a small rent for the vessels. Now we are doing the anastomosis of the vessels. How sure is that there is no twisting of the vessels?
There is no?
Twisting.
No, that they have made sure, because the lie of the vein really shows that there is no twist. You can appreciate that. If there's a twist, they'll be able to see that. And the hole is not that minute. A hole is quite enough. Even beyond the arteries, there is some scope. So once you take out the vein and the artery outside, you can appreciate that. I think it's quite appreciable, I think.
That's why the suture is put up for marking
No,
the
no,
orientation.
that suture, even yesterday he demonstrated that he puts the suture on the upper head, both artery and vein.
Just to
that is to identify which is the cranial part, which is the caudal part. I mean, which is the part towards the ureter, and which is the part away, the upper polar and lower polar, whatever you may call it.
So normally,
check नहीं किया, kidney ऊपर है कि नीचे है? आज चेक नहीं किया हमने, किडनी ऊपर है कि नीचे है?
ये तो आपको पता होगा कि किडनी ऊपर है कि नीचे है, कि आप ऊपर हो कि नीचे हो?
अरे आज वो चेक करना भूल गए, जब आप बता रहे थे तब ख्याल आया।
नहीं, यूरेटर तो दिख रहा होगा ना, यू मस्ट बी सीइंग द यूरेटर।
ये ठीक है?
लग तो रहा है, ऊपर बांधा हुआ है, नीचे खुला है, नीचे यूरेटर निकला होगा बाहर।
आजकल I am guided by my assistant, whatever they say I just do it blindly because I know they are right.
And the blame also goes on them.
No, you have got very dedicated and very hardworking and very well-trained associates.
That way I am blessed that we have a good team and there is a good coordination amongst themselves.
Yeah, that's very important.
And because of the good team and the anesthesia team, we are working on Sunday. So I would like to thank everybody, including anesthesia technicians, nurses, everybody who have come on Sunday to help us out.
Also the delegates who come on Sunday to watch this wonderful surgery.
Yeah, and yes, and thank you all the delegates who came on Sunday to watch.
No, I have done it on your behalf, yeah.
Thank you, boss. Thank you.
You know, Anand, just to see your wonderful surgery, I missed my golf today morning.
Oh, that's good.
So how can it be compensated?
You have to teach us how to play golf.
Next workshop we have half-day golf course.
Yes.
Yesterday there was venous bleeding. I don't want to have this today, so I'm just trying to take care of it. Now see, this upper part is lifted up. This is because the bowel under the peritoneum is lifting it up.
Yeah.
And patient is in a horizontal position.
And I find, Anand, the lie of the kidney just the same as it was yesterday in the transperitoneal.
We have learned the trick. We'll show you the trick.
Yeah, it is just the same. Only thing is the area is different. Otherwise, I think technique is almost the replication of whatever you did yesterday.
Yeah, technique will be same.
Yeah.
And the objection that open surgery is extraperitoneal, you doing transperitoneal, that objection will be removed.
Yeah. One more observation which I made was the dissection of the bladder was much easier in this particular approach as compared to transperitoneal. There you have to formally drop the bladder. Here you didn't have to do that. What do you say, Aditya?
Little bigger, so
you are a man with extraperitoneal and intraperitoneal. The difference which I found was, as we do in prostate intraperitoneal, we drop the bladder. It takes some time for the dropping of the bladder, whereas in this particular instance, extraperitoneal approach, the bladder didn't have to be dropped. So that time is saved, the dissection is saved. It was just lying in front.
that extra
Dr.
time is
Dr.
spent in
Kanebe is,
creating this space.
telling
Creating
us that,
this
he's
space will
doing
at
most
least
of the
take you 15-20
extraperitoneal
minutes.
prostatectomy.
Good time.
And that
But yes,
same
of course, the
dissection
bladder is
there.
not
So
dropped.
he's quite happy that this part is quite easy.
Only drawback I feel, once you have developed the space, you will feel exactly the same as you are in transperitoneal. But suppose something happens, you have to do suction. And you do suction and this just closes off because there's not much gas. In transperitoneal, there is a lot of gas is there. Even if you do suction, your insufflator has time to, make it.
That basic difference is always there.
That is there, but you see the way things are done, there will be very little need of suction. You may have
Something goes
No, if
out
it
of
is
the way,
when you open the
bleeding,
clamp.
something you're doing, you have to do suction then. Something goes out of the way,
When there
only
is-
in that situation.
Then you take off that gel port type of thing and get inside. You can dive in very easily because you already made the place.
Gore-Tex, double-armed Gore-Tex.
He has made it double armed. He has made it just like we do in prostate surgery when we start suturing the anastomosis between the urethra and the bladder. We put the knot beforehand, and in the similar manner he has done it there.
Actually, Gore-Tex is double armed only. Only thing is that we have to find a very small length of the suture, which is approximately 6 centimeters.
Yeah, that's
Otherwise,
what he
suture
said.
is very long. It's very difficult to handle a long suture robotically.
And somebody asked him this question yesterday, and he said, "Okay, this knot has been put in, so it saves him time. Now he will put only one knot on the upper end."
And that is
This is
pre-placed,
a
so
double-armed
I don't have to waste time
suture.
there.
Sir,
So Anant,
yeah,
by learning your answers yesterday, I am able to pass on the same thing without disturbing you.
yes, that's good.
See, he will pull the, after putting 2 sutures, he will pull the thread so that the adequate tension is maintained and there is no leak. This is what he said yesterday. So just to make his task easier and not disturbing him when he is doing the intricate job of suturing, I can convey those things to my friends. This is how he makes the sutures tight. And then this Gore-Tex suture has got the memory, and after some time they will slightly swell up. So minute so-called leaks they get looked after by themselves. Somebody asked this question because somebody may ask the question again who was not there, that this protein suture might bother. He said if it doesn't bother, we don't bother about it. If it bothers, we take it off.
Ethic basic principle applied. If something is not bothering, you should not bother it.
Boss, I am giving all your answers ditto.
He's already been tutored.
So I have been tutored so well by him that I have to just pass on it to my friends. And that is the beauty of a good teacher. What do you say, sir?
Now here this vein is a little bigger, so I am going to close this defect.
Yes.
Layer and layer.
Dr. Anant, what was your learning curve for robotic transplantation? Like how many cases you did before you felt very comfortable?
Actually, this is very interesting story, but I have been doing the transplant and I have been doing the robotic surgery, so probably it was easier for me to learn. But you know what happened? I think it was 2017 or 16. we did our first robotic workshop. I think it was 2016. And so we kept a patient for robotic transplant for Dr. Alawat to do. But that patient just 2 days before told us that no, as per his Pandit, that day is not good, you do 1 day before. And so we have to look for another patient for Dr. Alawat for the workshop, and I have to do it 1 day before. And that day I have not done the robotic, but I have seen the Dr. Alawat's video. So I called one of my students, Sanjay Gogai, who was working with Dr. Alawat before. So he came and he was standing there, and I was taking clue from him, and I did my first robotic transplant after the YouTube, Professor YouTube help and my tips from my student who worked with Dr. Alawat. And first case went well. He was making urine same day. So, but then struggle started. The first day God was lucky. I think Pandit was right. So everything went well. But after that I made a mistake. I thought that all the patient robot is good for the obese patient. So we have chosen the obese patient, and somehow at that time we got some obese patient from abroad, and then we struggled and results were not very good, and there was a longer time to do it, difficulties. So, and then after around 10 cases we became comfortable. So what I'm trying to say that never start with the obese cases. If you start with the obese cases, you will struggle. So you take the average patient, and when you are good in average patient, average BMI patient, then start the obese one. So I made the mistake.
That's a very interesting observation, because I believe that's probably what led to all those 10, 12 programs in US that started and failed and had to stop, because the general consensus is that it's good for obese, right? But that's not where we should start.
See, another difference is that here those who are doing transplant, they are doing lot of other robotic procedures as well, whereas in US they are doing only, they come only for transplant. That's why my feeling or my analysis is that why the transplant program, robotic program, has not taken off well in US.
You're exactly right, yeah.
Bulldog law.
Dr. Anant, what were the early complications in the first 10 cases? Was it just ATN because of long warm times, or anything else?
The first few patients, because they are very obese, one patient developed respiratory complication 4 days after the transplant, and he required cholesterol and all that, so his creatinine was high at the time of discharge, but he is still maintaining same creatinine after 6 years of follow-up. So that way, and then I think we took longer time to do the cases because all were obese, and few patients had urine output was slow to pick up, and serum creatinine also came normal around 10th day or something, which otherwise nowadays it is around 3rd day it is okay. So these are the few things initially happened. Now today God is kind, the vein didn't bleed. Yesterday somehow it bled.
ये तो खुद लगा रहे हैं ना.
वाला आर्म काम क्यों नहीं कर रहा है? ये वाला आर्म जो है, देखो क्या प्रॉब्लम है. चल ठीक है, हो गया.
OT3, you are on.
Hello.
Hello.
Yes, sir. We have declamped.
Yeah, we can see a very well perfused kidney.
And we can see diuresis on table.
Yeah. Good.
And hilum is clear. There is no bleeding. The artery is pulsating nicely. It's evident on the kidney.
Good. Do you always look for the pulsation distal to the anastomosis into the dorsal pedis?
I checked it.
Yeah.
Once we declamp, see the kidney, and we always check the distal pulsation so that there is no inadvertent injury or decreased vascularity to the lower limb.
So it is always good for my younger colleagues that whenever we use external iliac, number one, you must give a soft massage to the site of clamps, and secondly, you must see the distal pulsation, and somebody should also check the dorsal pedis artery because that is very, very important.
And once the patient is shifted to the recovery, we always check a dorsal pedis there.
Yeah. These are very important things whenever you use external iliac artery. Because complications of anastomosis with the external iliac artery are very horrendous, whereas the complications of using the internal iliac arteries can be reversed with much more ease as compared to external iliac artery.
No, काटने का दो, नहीं काटना. दोस्ती ये रहा ये बोलो
आपकी बार जाके वो पैराशूटिंग से ट्राई
So another important thing to note is the minute bleeding from the ureteric mucosa and the color.
Yes.
So that reassures us that our ureter is normal and it should not give us any trouble.
Yes. That mesentery should bleed always, and sometime you really find that there is a ureteric artery which is pumping very badly. So you'll have to secure that.
Yes, sir.
ऐसे डाल रहे हम तो गाइड बार डाल नहीं, और मैं इतनी जल्दी नहीं डालता, ऐसे डाल रहे हैं. मैं एक बार सूचक करने के बाद डालता हूँ. आई डोंट नो व्हाट इज इट डूइंग. अच्छा
पहले डाल के फिर
ठीक है, अगर इतनी सी लेंथ है तो फिर क्या फर्क पड़ता है. नो, हम ऐसे ही डालते हैं जैसे रोबोटिक वाले डालते हैं, एक बार करने के बाद देन वी Richard?
Yes, sir.
Do you put the this double J stent right away without securing the ureter to the mucosa of the bladder? Because I think that would be easier to suture one wall and then put the DJ stent. Otherwise, it will be dangling around all the time.
Sir, when I put a stent, I ensure that the ureter is not kinked and anything. Then I can spatulate easily in the most central position. So this is the advantage. Yeah, it dangles a bit, but then we are used to it over years.
You know, your professor says, Professor Anish is sitting next to me, and he says we put the dangle thing into the bladder and let it hang inside the bladder, let it dangle inside the bladder. At least you don't dangle with that. I think he's concentrating a little bit more. Yes, Professor Anand. Can we go over to Dr. Anand's OT? Hello? Can we go to Dr. Anand's OT, please?
Let's connect, sir.
Yeah. Dr.
Hello?
Anand?
Hello?
Yeah, we are with you.
Okay.
So nobody is asking questions because they are quite used to what they have seen yesterday. And if they ask any question, I am there to answer because I have heard you so well and I have registered almost every comment. Now this side there is no knot there.
So now Dr. Batial, you start doing the robotic transplant.
Yes, we have already started doing it. My friends, Dr. Rana is giving a smile. We have already done about, I think, 15 cases there. Though I have to put my hands on that, we're just waiting for the opportunity. But all your steps, all your comments are registered in my mind very well. I can reproduce them verbatim. I don't know whether I'll be able to reproduce them on the table, but verbally, yes. He will come to this side, then he will take another suture. Then he will put a knot there.
Sir is telling in artery most of the, sir was telling yesterday the artery most of the time if you put a knot like that, it doesn't hold good.
That tension which you want is not there. So he will pull this thread with the third arm, with the progress, keep traction, and put the other suture, put a knot there, give a little tug. So it will be tight. Then he will come here and put the sutures.
If there is a knot in the artery, it doesn't actually gets loosened. मैंने तो बोला है फिर वो चेंज तो करेंगे इसको बोलिए I think we are second group of chairpersons, third group is I think so. इनका प्राइम तो पूरा हो गया है 12 वैसे जिसमें वो सेशन है कॉम्प्लिकेशंस
क्या हमको तो उठा दो अभी बहुत हो गया इसमें
Thank you, Dr. H.S. Bhatyal sir, Dr. Anish Srivastav sir. I'd just like to change the chairpersons. Dr. Muruganandam sir and Dr. Aditya. Dr. Muruganandam sir and Dr. Aditya, can you please join us on stage, please?
जरा स्विचर ले आ।
This now the kind of magnification almost 7-8x. Patients are dramatically improved after that. Those who don't respond to any medicine or even neurotic drugs, gabapentin,
Cut.
Anand sir, we can see where the needle holder is grabbing the suture. There is some crushing. Is it a matter of some concern? Wherever that we can see some crushed area wherever we grab the suture with the needle holder. Is
Here.
it?
Yeah. Yeah, I know that. Yeah, you are right. We see that, but doesn't weaken it. I think that suture is quite strong. I know, but that is inevitable because you have to catch the suture.
One has to be a little careful. Once you start using the suture, a little bit of whatever you are seeing is all because of holding it. But when you hold and pull it, then you can damage it.
We use it for artery. We are using regularly using Gore-Tex suture. Maybe it is so magnified. That's why we are seeing it so much. So.
But you must have seen in when we do prostate and all, if we take this vicral sutures and if you pull it with the bipolar or with the other thing rather than needle holder, it gets torn.
It gets torn. Even the artery, if it does. But when we are doing it, we make sure the part of the suture which is actually going to stay in the anastomosis, that is not crushed. We only pull the further away part. In here, the suture length itself is so short, it is unavoidable that that area we may not be holding. Plus, robot doesn't have so much of sensation, how much pressure to give exactly.
Yeah, one has to be, you have to develop that sense. Or your assistant is so good that he always tells, sir, please don't pull it, so don't pull it. Good.
Excellent.
Excellent.
Anand sir, entire hall is applauding.
ये ले जाओ. इसका क्लैंप निकल गया, इसको फ्लूट दें.
Sir, are you planning to make a peritoneal window in the end for drainage of lymphatic fluid?
We made in first case. After that, we decided not to do that.
Oh, okay.
When we will develop lymphocyl, then we will see. See there. Caesar. एक छोटा सा स्नो यहाँ रखना पड़ेगा इस प्लेस पे, यहाँ पर देख रहे हो, there is a small branch which is not bleeding, may start bleeding later on. अभी रुक जाओ, चलो छो, अच्छा एक कभी बाद में रखेंगे, जरा इसको काट लें. This is the place I am saying there is, you can see something is jetting out. Just keep it support there. There's another advantage of this glove is it is easier to cut and remove than the gauze piece.
Sir, it looks very snugly fit. Is it a chance that it may be causing compression also because kidney distends once the perfusion starts?
I want to go to terminal 3. I don't have the objection, they don't have, no? You asked them, no? They don't have the objection. Okay, you send it.
It has come back.
क्या कितने बजे से है? थोड़ा सा डिले कर दो, बस निकलते हैं यहाँ से. लोगों को इसको देख तो लेने दो. Yes, I'll ask Samit to sit over for the ureter and then I'll go. Bipolar दो. फोन देखो. Now this, you will see the difference between transperitoneal is here when we try to put the kidney other side. The kidney stays in the middle and then we'll have to change the position of the patient, head down little bit. Only then this part becomes okay. पानी डालो जरा, कहाँ से हो रहा है? This is a tricky step. One has to be very careful. Take your time. You should not injure the kidney. पानी डालो जरा, पानी डालो। बताते हैं ना तुम लोगों का क्लिप सूचर सब लाइट वो होता है। Now see this difficulty keeping kidney remains like that. Now what we'll do at this stage, we will change the position and all the instruments, just let me show you the instrument. Now see the kidney stays like that because the bowel is pushing it. So at that stage what we'll do, we'll change the, your instruments are here. You can take out the instrument and change the position. Now at that stage we have to do some Trendelenburg position so that kidney sits there. That is the problem.
Should you increase pressure also, sir?
How much is the Nemo? हेड डाउन करना है, नीमो थोड़ा कम करना है। चलो ठीक लगा दो। That's all. Just that. So that is the point. Now you will see the difference once we did the head down at this stage. So that patient will remain in this position only for 15-20 minutes while I am doing the ureteric anastomosis. and then kidney sits nicely in the lateral space because the bowel will shift cephalic way, and then there will be some space creation. इंस्ट्रूमेंट डाले, अभी थोड़ा सा प्रेशर 15 रखो, जब एक बार एडजस्ट हो जाए तब करना तुम 15 कर दो प्रेशर. ठीक. Now you can see that in transperitoneal kidney is nicely placed. Here there is a struggle. You can see the urine is coming. Yeah. Okay, let me come here and create a space for the kidney to drop. Now kidney will sit here. तो इसको ले जाओ, इसको ले जाओ. गया? Okay. Suction. चलो इसको एलेक्सिस पोर्ट से निकाल लेना बाद में. We'll take it out later. ये तुम्हारा ये इंस्ट्रूमेंट देखो फोर्थ आर्म में अजीब से आ गई है. देखो फोर्थ आर्म में क्या प्रॉब्लम है. नहीं, फोर्थ आर्म जो है ये थोड़ा सा हाँ? अब ब्लैडर फिल करो, fill the bladder. Okay. अरे don't suck the ureter. Give me Caesar, I have to do the hemostasis. Okay, the lie is good. Hold the चलो सूचर दो. Now you can decrease the pressure to 12.
Roto 3 connect. Hello. Hello.
Ruchir, we are.
Yes, sir.
Yeah.
How are you?
Fine, fine, Ruchir. Superb surgery is getting over.
So we have done everything now. We are on the verge of closing. So before we close, I am just going to show you the pedicle. एक और देना. Kelly retractor, please. So I wonder if you can appreciate.
Yeah, the vein edge
This is
we are
the
able to
vein,
see. Yeah.
and here is the artery.
Upper. Okay. Yeah. Yeah. Just above
Okay.
that.
So there is no oozing or bleeding.
Yeah.
I'm not putting any surgical here.
Okay.
Now the last step is to put a rhombolic suction drain and check the drain exit site.
Drain you place laterally or medially?
Pardon?
Drain where normally is placed?
Supralaterally.
Okay.
On the supralateral aspect of the incision.
Okay.
And place it posterior to the kidney and towards the ureteric anastomosis, ureteroneostostomy.
When you will remove the catheter and drain, the protocol?
Catheter we remove on the day 5.
Okay.
A drain usually when it's less than 50 to 75 ml.
Yeah, you are good. Please go.
So this is a case of ABO incompatible transplant. I expect drain to be on the higher side. It may take a little bit while. When it comes down, and we'll remove it.
What is the size of the drain you are putting, Ruchi sir?
It's 18 French.
Okay.
So once we put a drain, we just check if there is any bleeding from the exit side, because this is one of the most notorious sites. If it bleeds, it can lead to re-exploration.
What are the extra points you would like to tell for the surgeons, the difference between the compatible and ABO incompatible transplant, surgeon's point of view? What are the tips you would like to give?
So only difference is the drain output is a little bit on the higher side.
Is it bloody
Otherwise,
or
during
serious?
intra-op and everything, there is no problem. Only it oozes a little bit more.
Okay.
So we have to be a bit more meticulous on hemostasis.
So
So
all
before
patients, the
I
immediate
go for the
diuresis is
kidney, I ensure that the bed is absolutely dry
there. Okay.
before I start anastomosing.
And
So if at all it bleeds, I will be sure that it's only from the kidney and not from the bed, which can confuse.
most of them do get the brisk diuresis like your usual cases.
Pardon, sir?
Diuresis you are getting in all cases as usual.
Yeah, diuresis we are getting. So I will be mobilizing a little bit of sheath to ensure that the closure is effortless.
Okay, okay. I think when you are doing, the people are appreciating your how meticulously you do each and everything, like starting from the bench, preparing the bed. You got a good appreciation from the senior people.
Ruchir,
Yes,
one
sir.
question about that drain. Your field looks good. Do you really need to put a drain?
Yes, sir. It helps me a night's sleep.
Yeah, I haven't put a drain in any of my transplants in last.
Yes, many
several
centers
years.
don't put it.
Yeah.
I've been seeing everyone putting drain since my training days, so I'm still keeping it, not going for too much of adventure or as of now.
But very good transplant demonstration, surgical technique, handling of the vessels, everything was really good, Ruchir.
And being
Thank you, sir. Thanks a lot.
Being left-handed, how particularly the advantages you felt in doing transplant, standing from one side or doing the left side the implantations? Anything you have got advantage over the right-handed person you felt?
Sir, the only thing I feel good is when I am doing it. So I am able to take the artery inside out.
Okay.
On both the walls.
Okay.
So it gives me a bit more confidence that I am taking the intima properly and
Okay.
should not be any deception, especially in the external iliac one.
Dr. Ruchir, would you agree the convention of putting kidney on the right side was designed by a right-handed surgeon? So most of the time you are at disadvantage while you are putting kidney on the right side.
Maybe so, sir, but I got used to it and it suits me now. And that way, all the instruments are made for right-handed surgeons. Even the scissors we use, we have to use it in our own way.
Okay.
So invariably a left-handed surgeon is mostly ambidextrous because he has to adjust to right and left both.
Yes, sir, yeah, that's very true. So once I had this discussion with Dr. Pranjal Modi. So he is also a left-handed surgeon.
Yeah,
I asked him, sir, how do you manage it? He said the only way to is to learn to use the right hand, that's it.
In laparoscopy also you are using mostly your right hand.
I use both the hands, sir.
Yeah.
In laparoscopy, I'm quite
dominant
happy
dissection means the counter traction by the non-dominant hand and dissection by the dominant. That's you are doing with right hand. I observed you specifically.
Yeah, I can modify it as per need.
Yeah. In open surgery, we are able to make out it's being done by a left-handed surgeon, but not in lap.
Thank you.
Needle.
Urine output?
Hmm.
Can somebody tell me about urine output, please? And the color also.
So what is your protocol of doing the Doppler intra-op or the first post-op day, or you don't do at all? Ruchir?
No, sir. Not usually. If we are confident the kidney is producing good urine, all parameters are normal, we usually don't do it. But yeah, our nephrologist, they have got different idea.
Hmm.
Sir, we are, as of now, bag contains 250 ml of urine.
Yeah,
the color
good.
is okay, clear.
Good. Excellent demonstration, Ruchir. All of us appreciated your skills. Great.
Thank you, sir.
Thank you very much. Thank you very much. So, yeah, you can hear the applause from the audience. The kidney looks very pink on the half closure. Can we go to Dr. Anand Sir Soti?
Oh, yeah. ये अंदर चला गया क्या थ्रेड?
ऊपर से जा रहा है अपना मसल नीचे.
Dr. Anand, over to you.
Yeah. So we have hello.
Yes, sir, please, sir.
Yeah, we have finished the one wall, put the stent, and now we are finishing it. So you have seen that there is one difficulty was there to place the kidney lateral side at its resting place.
Yes, sir.
That we could, first case we couldn't figure out and we struggled and left it like that only.
Okay.
But then second case we figured out by changing the position it worked well, and end up the when we'll be removing the pneumoperitoneum, then we'll do another maneuver to place it nicely.
Any specific tips for the insertion of stent in robotic uterine implants, sir? Use the closed end, or we have not seen at that
What
time.
you are saying?
Any specific tips in putting the stent in the robotic surgery?
I think you saw that it is straightforward. We never struggle to put the stent.
Okay.
And once we do the one layer, then we just put the assistant bring with the guide wire in.
Okay.
And we just put it. So we never seen that there was any difficulty in putting the stent. The only difficulty is if you are not putting at the proper place.
Okay.
Then it might go here and there. Sometimes it has gone to the bladder. And but once you realize that where is the place to put it, then it just straightway goes up. So putting a stent has never been a problem.
Okay.
But there is many ways of doing it. People are putting beforehand.
Okay.
So we have not tried that. We can try that. In Europe they do it.
So we'll be watching the surgeries. There is one talk. We'll invite the speaker.
Yeah,
Dr.
please
Vikas.
start the talk.
Yes, sir. Thank you, sir. So the career in organ transplantation for young urologists, a road to success. Dr. Vikas Singh, please.
Thank you, Chairperson. Is it on?
Hello. Thank you, Chairpersons. Shall I start?
Yes.
So, my name.
Yeah, you can proceed.
So, good afternoon, everyone. I am Dr. Vikas Singh. I am working in Kokilab and Dhirubhai Ambani Hospital, Indore, currently. And being a young transplant surgeon, I would like to give some advices to my colleagues and young urologists about their plan in the making career in transplant surgery. So, the agenda for my talk would be how to start your transplant career, when to really get going, means when do you want to become an independent transplant surgeon coming out of your bigger team, and to make sure that there are going to be some troubles on the way and how to navigate through those troubles. So this is the agenda of my talk. So why am I talking at all? So what credentials do I have? Let me go through a little bit. I do not say that I'm having a lot of experience in the transplant surgery, but I can say that I have seen a lot of different aspects of transplant programs. I have been into transplant training before my MCH training. I started in PGI Chandigarh in transplant department before doing MCH. Then I continued transplant in my MCH training also. Later on, I joined Max Hospital Saket, which is a very high volume center. Then I went on to a trust hospital in Indore, shifted to a tier 2 city, and did quite a few numbers over there also. And then now I'm in a pure corporate hospital trying to set up a transplant program over there. So I have been a part of almost 600 transplant cases. I have done independently more than 100 cases now, and I have no plans to quit it. And currently I'm practicing all the urology cases also. So first of all, let me tell you that it is not a difficult surgery to perform. The transplant per se, for a young transplant surgeon, it might feel intimidating to you. The kind of surgery that Dr. Nand Kumar has shown you, robotic donor, robotic recipients, sometimes you might feel that it is a bit too difficult to perform. But unless you land up in some kind of complications, it is not a very difficult surgery to perform. I divide transplant surgery into 4 categories, how you do it. Donor surgery, the bench surgery, recipient surgery, and the challenges that come up with the complications that you are going to see along with the transplant cases. So first 3 parts of the surgery, the donor, bench, and recipients, I believe they can be done on a template basis. You get trained in a good high volume center, you set up a template, how to perform a donor, a bench, and recipient. You just follow the template and you can perform all the transplant cases. There will be some variations, but mostly the template remains the same. It is only the challenges and the complications that they come up later on in your career, then you need to improvise a little bit. But otherwise the surgery, the transplant surgery remains pretty much template basis. So if it is such, if it is not a very difficult surgery, then why aren't many urologists doing it? There has to be a reason why not many people are doing it. Only few choose to go into this field. So I have summed up some of the reasons that I could understand in a small career. There might be some of them that I have missed here. First of all is that exposure. Most of the government medical colleges at the state level are not giving exposure to the residents about the kidney transplant. I don't know about the other states, but my state, the Madhya Pradesh, I think only 4 or 5 transplant cases in government setups have been done, and the private setups are doing many more. So first is the exposure, second is the support, or rather lack of it from the government side, especially for the government medical colleges of the state levels. Third is the dependency on the other departments. You need to have a good nephrology department. If you don't have a good nephrologist who's keen in transplant programs setting up, then you won't get any cases, that is for sure. They will all keep on leaking. And not only the nephrology, you need to have a good pathology department, good microbiology department, good pulmonary department also. That is also a requirement. And the last but not the least is the fear and the negativity that is associated with the transplant program. Because many times you are seeing and hearing the news of all the those investigations, those you know what I'm talking about. So that goes along with the transplant program. So recently, few days ago only, I received a call from some unknown caller telling me that he wants to kind of sell his kidney. He just straight away called me that I want to sell my kidney. You don't need to reply to those calls. Don't say anything. Just disconnect those calls. So be mindful of that. And that is one of the reasons why many people don't want to indulge in this program. So let's start our discussion how you should get trained. The first and foremost question that comes up with the transplant program is whether you should carry on with urology practice or you should dedicate yourself totally towards the transplant program. So my suggestion would be that it can be done. Many of the stalwarts are doing only transplants and they have done wonderfully. So before doing MCH, I was in PJ Chandigarh and they had a department which is exclusively doing renal transplant only and the associated procedures like AVF creation. But my take on this contention is that unless you are into a government sector, you are keen to join a government sector, try to continue with your urology practice. It will give you peace of mind because you'll always have a plan B ready in case something goes untowards or some regulation or anything comes up that is not comfortable with you, you have a plan B ready for you. And definitely money matters here because urology brings definitely a bit more money than the transplant can bring. So my first suggestion for a young urologist who has just passed and has not got enough exposure, is not confident enough, would be to join an overworked team. So what do I mean by an overworked team? Where there are so many cases happening that nobody is actually ready to, at least start the case. They are ready to perform the cases, but at least you get to start the cases if you are working in an overworked team. So there are many centers in Delhi and Mumbai where the teams are overworked. So you get to start, you get to prepare the bed, you get to start the donor nephrectomies, then you start getting to see the large vessels, you see the hilum, so you reach the hilum, and then later on you progress to complete the donor nephrectomies, and sometimes you start getting into the anastomosis thing also very quickly in the overworked team. So there are, as I told you, there are certain benefits if you are into a big team. You'll get to see a large number of the cases, then the variations, you'll get to see the multiple vessel cases, you'll get to see horseshoe kidney donors. So not only that, you'll get to know about the new techniques also, like robotic transplantation program that is that we can see here being shown by Dr. Nandan Kumar sir. And also with the number of cases that are being done in bigger units, you'll get to see many complications also and how to handle those complications. So these are the important points that you get benefited with if you are working in a high volume center during the initial period of your career. While you are getting trained, I would suggest you to buy some gadgets. One of the important gadgets for a transplant surgeon would be a loop, a good loop. So it need not to be a costly one. There are some cheap Korean-made loops are available here in Delhi. If you want to know about those vendors, you can connect with me. I can suggest you. Why I'm telling you that you should buy a loop early in your career is that because you need to spend some time with the loop to get accustomed to the kind of distance it needs to be your head from the operating field. The kind of magnification it provides, sometimes it becomes intimidating initially. So you need some 6-7 months to adjust with the loop. So try to purchase it beforehand. Before you are supposed to get your hands on the anastomosis thing, real thing, at least 1 year before you should purchase the loop. Then try to figure out what are the necessary things which are factoring in the transplant surgery. One of the important thing that I think it has been missed here in the this conference is the needle. In open surgery, the needle size, the curve of the needle, and the thread. These are very important parts. Apart from the needle holder, I think needle holder was discussed here. Many are preferring Castovajo, many are preferring simple needle holder. I prefer Castovajo now. I started with the simple needle holder. About the needle, I started with a 13 mm needle, then I went on to 9 mm needle. Now I'm comfortable with the 11 mm needle. So you will find a comfortable size of the needle. You will find a comfortable needle holder, and try to learn this omni tract. This omni tract is an important thing because this makes life very easy for the recipient surgery. It's a costly one. Maybe your smaller hospital will not provide, they will resist. It comes in lakhs, 4 to 5 lakhs, I guess. So, but if you purchase this one, the things become pretty easy all the time of those retractions, and the number of assistants that you need comes down drastically. For donor nephrectomy, I would suggest you to follow just make a template, whatever your training institute has told you, just follow the template, and that would benefit in your later on radical nephrectomies and simple nephrectomies also. Just follow the template, how you have been trained. That makes the donor nephrectomy very easy. You are able to finish donor nephrectomy within 1 hour. Try to master your AVF creation. Fistula creation, if you master, the anastomotic technique, if you master, that will help you in your real game that you are going to get in the later on in your training period. And this is how I would suggest you how to learn the anastomosis. First you learn the ureter anastomosis, which is the easier one, but it does come up with the caveat that if the complication is created, it is the most difficult one to deal with. Then progress to the venous anastomosis, and then at the last you do the arterial anastomosis. That you will get to do in a big volume center. And if you are part of a big team, as I told you, there will be some complications. Try to remain alert. There will be times when you will be called to come up at the midnight to burn some oils and see the complications. There will be some re-exposures. So try to learn how to re-explore those cases. Many a times you will be able to assist in those cases. Try to learn how to re-explore, because that is an integral part of doing transplant surgery. Now comes the question, how much exposure is enough if you are in a big team? So how long should you stay in that big team? Sometimes it becomes very difficult to judge whether you are aptly trained now or not, whether you are able to where you will be able to perform it independently. So sometimes you get confused about your own confidence. So my suggestion would be, because I left at a certain period where I was in a same dilemma whether I was aptly trained or not at that time. So my suggestion would be that by the time you have done around 10 arterial anastomosis, 20 venous and 30 odd ureteric anastomosis, I think you are trained enough to start your transplant program at a smaller center or a different center. So my suggestion would be to achieve at least this level of training before you indulge into an independent program. So next question would be, I have got enough training, I have been into a larger team, what do I do? Shall I shift to a tier 2 city or remain here in tier 1 city? So that is a big question. So that is a totally independent choice, personal choice, subjective choice. You can decide upon your career preferences, but in tier 1 cities, I see lesser opportunities for younger surgeons to get a chance to perform transplant independently, set up a transplant program. If you move to a tier 2 city, if you are coming from a tier 2 city, your hometown is tier 2, it would be better this is my personal advice, this can be very subjective. My take is that you should shift to a tier 2 city where you'll get ample chance to set up a transplant program. So when you move to a smaller city, it is not all rosy over there. There are many challenges of being in a smaller city, tier 2 city. So some guys have overcome those challenges. One of those is sitting here in the chairperson seat, and many are still struggling with those challenges like me. One of them is that it is totally controlled by nephrologists. The transplant program in smaller cities is totally controlled by nephrologists. They will decide when to post cases, they will decide which case to take up, they will decide which case to reject. So you are hardly asked about it. So this is, at least this is what I am facing. I am telling you very blunt truth. There will be limited patient access. I mean, here in Delhi we see that around 1 month before the transplant is posted, you are constantly being exposed to the patient, prospective patient pair. But in smaller cities, they will 4 or 5 days ago, the date that they are proposing for the transplant, they will tell you that we have prepared this pair, so kindly go through the pair. So you will get very limited access. And after surgery also, many times they, once the patient is discharged, many times you won't get to see the patient once the patient is discharged. So many times I have seen that patients who I have done transplant 1 or 2 years ago, when I ask them, who has done the transplant on you? They'll take the name of the nephrologist. They don't even know who you are. So many times these kind of problems do occur in smaller cities. Please be mindful of that. Armamentarium is less in smaller cities. Smaller hospital obviously will have lesser armamentarium. The staff will be less trained. Sometimes the staff will get trained and they'll move away. You'll be left with your own. There is no DNB resident. So these kind of struggles do happen in the smaller cities. One important aspect is that you have to plan your leaves. If you are the only surgeon, you have done transplant 2 days before, you can't leave the city. If there is a transplant planned 3 days ahead, then you can't leave the city. If you are in a big team, you can take leave and the other of your colleagues will take care of any of the complications that can occur. And the stress levels in working in independent situation is definitely higher than working in a team environment. So these are the negative things that come up with the smaller city movement. So, but apart from these problems, transplant surgery does give you some benefit. Surgery per se, I'm not talking about the transplant program, I'm talking about the surgery. If you perform the surgery, you refine your surgical skill, you get to handle larger vessels very confidently, you get to see large amount of bleeding also, you know how to tackle those bleedings, you get to see how to handle Satansky and all. The pelvic anatomy you become very confident about, the laparoscopy you become very confident about, and social recognition in smaller cities is something that I have seen that because not many urologists are doing transplant, so you quickly you get recognized among the urologists that this young guy is doing transplant. So it's a way of getting security of your job as well as social recognition. So what is the road to success? Let me sum up some of these points that I have elaborated. So these are the points. start early, as I told you. If you are late into the your journey, then it will become difficult and difficult. Complete your urology training first, and then try to indulge into the transplant program, because then you'll have a plan B ready for you. Join a high volume center with a good mentor, where you'll get to expose many of the cases. You'll get to deal with the complications also. Preferably shift to a tier 2 city which is in need of a transplant program coordinator and surgeon. Make a small team with like-minded people. That is very important as per my opinion, because if you are not in sync with your nephrologist, it becomes very difficult to continue with the transplant program. Sometimes they will, sometimes the arguments will come up. I mean, there are some complications in the post-op period, so the blame games and all those things go on. So it's better to have a like-minded team and be ready to learn always, because there will be some changes in the transplant practice, so, and the government regulations, so please be ready for that. So that ends my presentation. It's a small and non-academic type of presentation. Thank you very much. Any questions? Most welcome.
Very nice presentation. Just two things.
Yeah.
Setting up your own setup in tier 1 city is easier than tier 2 if you get an opportunity, because you have lots of backup. Many senior surgeons will be in tier 1 who will be ready to come and stand behind you. So that's one benefit in tier 1. Second, money. You are doing urology for money. If you start admitting recipients for complications of recipient like BK virus, PCP, CMV, pneumonia, simple fever, this money problem will go away. You don't need to do urology for money.
So let me tell you, friend, but as I told you, many times you won't even see your post-op patients. So how would you admit those BK virus patients?
And one more thing is, who is signing your form 4? If you are seeing the patient 4 days before, who has signed the form 4 authorization?
Yeah, you get to sign those.
So if you are signing them without seeing the patient, then it's an issue.
You get to see the patient, but here what I have seen in Max, that you at least get
so before
15 days of time to assess the patient. And in smaller cities, what happens is that it becomes kind of an urgency. Sir, ye to patient hai, we have posted it for next week, please go through this patient. So there is an added pressure here. If you are in a big team, you can sometimes say no, but in a smaller town, what happens is that you are sometimes forced to perform transplant. It happens. It's a reality. I don't know. You may disagree with that, but that is my take on that.
Vikas,
yes, sir.
I have an opinion on this. See, first of all, in any hospital, see, nobody can force you to do any surgery. First of all, if anybody is doing it, you should know that you need to formulate a methodology how you prepare your patients.
Yeah.
Sit with nephrologists, discuss with them. This is for the betterment of the patient, and it is not a tussle that whose patient it is. If he is getting the patient, of course it is his patient. He should not get a sense that surgeon is trying to grab the patient. If you are only doing the surgery, let the patient go back to him.
So I'm
that
following,
sense
yeah.
should not come, and always make a protocol that this is the first level test in which urologists will see, nephrologists will see. So these many clearances will be done. We will review. Again, the counseling, I think the video counseling you must be doing already.
Yeah.
So it is not possible that you get enough time to introduce yourself, tell the patient that I'm going to be your surgeon, I'm doing your surgery, this is how the surgery is done. See, as a surgeon, we spend most of the time in OT, and we get very little time to spend with the patient. In the follow-up also, we just go and see drain.
You see the drain and come out. Everything is fine. Creatinine is normal.
So spend time with the patient. Spend time with the patient's family. So this insecurity should never happen. That okay, patient को पता ही नहीं है कि किसने surgery किया. Patients are not, I mean, that dumb. They know. I mean, once you spend time, because the medical side people, they always get more time to spend with the patient. Nephrologist round would be there half an hour, 30 minutes, 40 minutes. They are there with one patient. And as a surgeon, most of the time we go, urine कितना है, drain निकाल दो, dressing कर दो, ठीक है.
We are happier if we see less of them. We spend lesser time with the patient. We are happier actually.
Once you have done the surgery, spend time with the relatives, tell them how did the surgery go, what were the difficulties, what were the problems, how you manage them. So these things will give visibility, and making a protocol with like-minded nephrology.
Yes. That was the precise reason that I have plans to. I've shifted lately, and I'm trying to set up a program according to these things. I mean, I would keep in mind that these things are taken care, that you that the problems that I have shown here about the tier 2 cities, that I'm trying to address those problems. Anybody else?
Good afternoon, Dr. Vikas.
Hi,
very
Himanshu.
nice presentation.
Thank you so much.
Dr. Himanshu Sharma here. So, sir, first of all, you very nicely charted down and jotted down all the points that we, that probably could be the hazards to start, or maybe the some hurdles that you have to cross to reach at a point where you start your own program. I also agree with Dr. Aditya. I definitely agree, sir. Spending the time with the patient, it definitely helps. I feel that whenever I also start, interacting with the patient, I take some time to point it out actually that nephrology is going to manage the medical part and I'm going to
You
manage
have to
the
do it every
surgical
time.
part.
Every time
Yeah.
you have to tell them.
But sir, I'm working in Mumbai. I find the biggest challenge there, and as you pointed out, in smaller cities, not only in tier 2, tier 3, even in tier 1. So the control of nephrologists, like I am actually astounded. I saw it for the first time.
Because you are trained from Max.
Yes,
so
yes.
That is a surprise for you.
I have also worked under Dr. Kishore TA in Kochi. There also it was a nephrology control program, but we had like our independence. I am astounded that I actually also want to ask Dr. Oswal, I don't know whether he's here now. So the nephrologist is defining different teams for the donor and the recipient. This is something I saw for the first
Unheard
time.
of.
Yeah.
So
no, in fact, a different surgical team for the recipient, a different surgical team for the donor, absolutely no interaction before the day of surgery between the two teams.
Yeah.
So I don't know how legally feasible this is.
This is happening because as a surgeon, we are letting it happen. Some things happen because you see, it's always, if you don't do it cheap, somebody will always come and do it cheaper. So it's up to person how much they are able to, willing to adjust. It is not medico-legally also, both teams have to be in sync. Donor, afterwards you can't say, this is the kidney I got, what can I do?
Yeah, exactly.
So I think it's totally up to you. You have to get that rapport with the, you have to build a good team. It need not be that you just want to do some surgery, somebody should allow you to do.
But sir, legally, where do we stand on this? Can we have two different teams?
They can be registered, I guess, as a transplant team, in the hospital. So there is no problem legally what part of surgery you do or you don't do. But definitely the surgeon who is operating surgeon for donor, they are responsible for the donor surgery and safety. Recipient who is doing, they are responsible for the recipient surgery and safety. So legality is as such, there is no law observing who has done the surgery, why he has not done the surgery, or why patient does not know that you have done the surgery. Legalities only happen when something goes wrong. That idea you have to transfer to the nephrology colleagues, that this is how we want to develop the program. Obviously, there will be people who are already doing things in certain way. It's up to you whether you want to join that bandwagon or not.
So I think probably you go with the flow initially and then put your foot down at some point.
Kind of happened the same thing with me. I did 100-odd transplant in a team where, in a setup where I was not very comfortable, where I was not being given enough space with the transplant program. I was kind of, going with the flow, because it's a very old, it was a trust hospital, very old program, almost 30-40 years they were running this program. So there was a proper setup, so I could not change anything. So now I have joined a new place where I am setting up a transplant, so the things will be done according to my choice, at least some of them. At least those that matter me most, where I need to, put my foot down. So I'm making sure that my take is taken well within the reach by those new management. So my suggestion would be to first get trained and then try to be in a team where you have like-minded people. There is no poachy kind of a behavior where you want to take away all the patients. So that is one thing that I have faced in tier 2. So that I thought I shall share it with you all.
Thank you so much.
Thank you, Dr. Vikas.
Thank you, sir.
We move on to next session. I guess this is
Meet the Professors session, case discussion on complications related to renal transplantation.
Yeah, I'd like to thank Dr. Aditya and Dr. Muruganandam. And for the next session, I'd like to call upon Dr. Rajiv Sharma on stage and Dr. Anish Srivastav on stage. Dr. Anand and Dr. Tanabe will also be joining us. This session was supposed to be moderated by Dr. Samit or Dr. Ruchir, but they are busy in the OR, so it will be moderated by Dr. Swapnil on their behalf.
Good afternoon, sir. Good afternoon, everyone. So I'll be discussing some of the complications in form of case presentations. So let's take the first case. So this is a donor nephrectomy being performed. So while lifting up the ureter and dissecting it, so in an attempt to desperately control the bleeding, the ureter got injured. So how this could have been avoided, and even if it has occurred, then what should be the management of these injuries? So this could have been avoided by careful meticulous dissection of the ureter and the ureter-gonadal complex, and even if would have occurred with someone, then either if the length is good, then directly uretero-vesical anastomosis can be done, or it could be ureter-urerostomy with the native ureter. So what are your thoughts on this?
Here, I saw that this dissection was being done between the ureter and the gonadal
complex. Yes, sir.
So, but generally we always take the gonadal, so that triangle.
Yes.
Right side.
Right
It's
side.
for the right side. Okay. No, then it is fine. I mean that way. So yes, the option is because that ureter looks quite avulsed.
Yes, sir.
And I don't think there is any way except that you have to use the native ureter in case it falls short, or a small body flap if you wish to take. Otherwise, yes, you have to take the native ureter. Use the native ureter for this. Although generally when we use the native ureter as an elective surgery, then we make sure that that ureter is not dilated or it's not refluxing, all those things. But here, this becomes an kind of a salvage situation.
Yes, sir.
So that is the thing.
I thought you're too close to the ureter during the dissection.
Dissection.
Is that we can use a firefly sort of thing to see the vascularity, and secondly we have to be very generous in discarding the ureter, because even if you're going to cut it at just proximal to the injured part, because of the thermal injury later on we can have some ischemic complication. So we should try to cut the ureter generously and try to give enough length proximal to the injured margin, so that later on we should avoid the vascular.
Vascular.
So what was actually done?
So enough length was there, so it was directly in osmosis. So this is another case.
Not hear it. What was done to that case?
So the ureteral length was sufficient, so it was directly anastomosis to the bladder.
Sir, you said you can use the native ureter and do ureterostomy. Suppose if the native ureter's output is good.
Suppose?
Output of the native kidney is good, about 500 ml in 24 hours.
Yeah, but generally what we have seen...
Then we have to ligate the proximal
Yeah, we have to ligate, and it doesn't matter actually, they atrophy. So
the output is good still.
See, that is what generally such situations we do a pre-operative workup first. But here this situation is a salvage situation. Okay, but whenever I have ligated earlier, so it has never given us trouble. And in case it troubles, you can then go for the nephrectomy later on.
So best answer of this problem is this, that we have to inform the family members that there was some issue. We have to ligate the native ureter to complete the procedure, and you have to tell them that in future he may require a native nephrectomy because of this. And that is why it is always important to write this line in the consent also, that because of some emergency situation or some inadvertent injury to the structures, you may require some additional procedure requiring the help of some additional surgeon also, and later on also you may require some additional evaluation and treatment for that complication.
So this is the second case. A donor nephrectomy is being performed.
Any pre-op CT angio was there for this patient? Hello?
Yes, sir, there was a upper pole accessory artery. So it got injured during this dissection.
Yeah.
How big was that on the CT?
और लोग कर रहे हैं एक्स्ट्रा पेटिंग देखना नहीं मिलता
सिंगल पोर्ट में किया है कहूँ में
अच्छा
या आपको सिंगल पोर्ट
vascular anastomosis at the quick like just like open and everything, it was awesome, very impressive.
तो किडनी प्लेस करने वाले चाहिए उनको ऐसे खड़ी रहती है फिर उसको
So there was a 2 mm upper pole artery which was injured during the dissection. So I'd like to ask that if this would have happened during dissection, then how would you manage such kind of injuries?
2 mm, I would just sacrifice it. But again, you have to be careful. Like if you already know there is a vessel where it is going.
Yes, sir.
Just careful dissection, basically.
So this was a very small vessel and supplying less than 10%, so we have just clipped it.
Yeah. Upper pole usually never really causes that much problem. I've had like cases where it was supplying 15-20% and got inadvertently taken, and the kidney function did not suffer much.
And sometimes what we have done, we put the clip and just finish the operation.
Yes.
And then looked at it. If looked at it is to be anastomosed, then we
Then
just either
reconstruct.
reimplanted or just anastomosed or something. We did it.
So I do exactly the same. I'll clip it, and after reperfusion, I'll see what it looks like, and if something needs to be done. Sometimes I'll leave it open because these are tiny arteries. That's a good way to see the backflow. I'll even flush through that just to see whether the area of discoloration is improving completely or not. Sometimes you'll find that it's not. You know, even if you try to reconstruct it, it's not going to do much. So in that case, you just have to take it.
Yeah, if you are left with a small stump and suppose it's supplying 25%, this artery was small anyway. So in that case, you can take a part of inferior epigastric and just lengthen it and then put it.
So this is the next case. So there was a retroaortic left renal vein. So there was an injury to this vein during dissection. So we managed laparoscopically initially, but in the end we have to convert it into open surgery, and then the donor nephrectomy was performed. So sir, any tips for approaching that retroaortic renal vein, and how could we avoid such kind of injuries during dissection?
See, all these things are basically, you have to be very careful actually. That is the only one word which we can say. There are, with these retroaortic branches, actually, they have lot of small tributaries coming up. So whenever you dissect a totally retroaortic vein, then you have to be actually extra cautious, and you have to keep seeing that there will be lot of tributaries coming. That is where this problem happens.
Yes, sir.
And you have to anticipate and then clip them properly.
In the hand-assisted approach, it is so much easier. I usually have a lap also, so if you have some bleeding, you can put a lap, put manual pressure. You can easily see what is coming from where. It's easier to control. So hand-assisted approach has that added advantage. You don't have to. I don't use suction much because of the lap. I just change the lap, so it's really easy to control. But again, you have to be careful. Like the previous one too, you just have to be more careful in the dissection.
So are you still doing some hand-assisted?
I only do hand-assisted.
Hand-assisted,
Yeah.
okay.
So coming to the next case. So this is a right side donor nephrectomy being performed, and stapler was applied. So the right renal artery was injured while we were dividing the renal vein. We have tried to apply a hemolock over that. But you can see that now the stump is only having a metal clip.
So it is left with only a metal clip?
Yes, sir.
Okay, so maybe either try to, retract the IVC very gently, do it, or go into the interaortocaval plane,
yes,
and there you can put another good clip. I think that is the way out.
So we have managed the case with going into the interaortocaval groove. So the artery was clipped in the interaortocaval groove. Next, coming to injuries caused to the kidney, such as hematoma and the parenchymal lacerations, either during dissection or while retracting or while putting the kidney outside. So how to prevent and what should be the management of such kind of injuries in case of capsular tears or in case of parenchymal injuries?
How frequently have you had parenchymal injuries during retrieval? Like it's extremely. I've never seen even one.
During retrieval is extremely rare, but while retracting the upper pole sometimes, or while lifting up the kidney with the retractor, sometimes there are subcapsular hematomas.
No, I'll
but
tell
very
you what happens. That surgeon is doing it, and the assistant is keeping we usually keep the fan detector to detect the lower pole. And so surgeon is asking his assistant to put little more traction, and in laparoscopic everything is counterintuitive. So if you have to press it like that, you have to press this way. So while doing pressing it, the assistant is pressing too much, and this I have been telling them not to do, just do the retraction, and that's how this parenchymal injury occurs.
Subcapsular hematomas are not uncommon, but parenchymal injuries.
But these are the very minor, small
Small
parenchymal
is
injury.
fine,
You see a blue spot, and when you perfuse, most of the time everything is okay. But there is a subcapsular hematoma little bit, so you might have to open up. But that only happens because of the assistant resident is putting more pressure to.
So generally when we observe, so there are two things. One thing is, as he said, parenchymal injuries per se are extremely rare. And then you can see, after perfusion, how it behaves, maybe put a Surgicel there, small tear. The more common injuries are the capsular tear, and they could be either very well seen, when you have retrieved the graft and you are perfusing. So that is one. So in that case, you can see if there is a very small tear, better to just enlarge it little bit more, so that whatever oozing is there from the raw parenchyma, it comes out and nothing happens. The important situation or the more complications occur when you fail to realize that, and you release the clamp, and then you see a blue tense spot, upper pole, generally
Yes,
upper pole or lower pole. That is where it is important to just watch for some time, see if it is increasing in size, or as a prophylactic thing, you can just open it and make a little larger incision and nothing happens. Because if you keep it like that, sometimes that hematoma can enlarge, it can dissect all along the kidney
and capsule.
And I remember on one occasion when we were wheeling the patient out, and then we realized his urine output was, good diuresing kidney to begin with, then urine output was close to zero. And then we immediately reopened and we saw that the hematoma had, engulfed the whole kidney. So it's a kind of a page situation. So then you have to make a good large incision on the capsule and take care of it.
We routinely open all the hematomas.
Yeah, it's
nice and wide.
better to nice and wide open.
Yeah. Regarding the capsular tears, I once transplanted a kidney with nobody had accepted that kidney. It was from a deceased donor, so there was no capsule, a complete capsular tear. And those kidneys, they bleed like crazy. So you have to
it's covered with surgery.
That's exactly.
Then you can
and
put
just
pressure.
Yeah.
It takes a long time.
Yes,
It takes
just
about an hour or
seconds.
so.
You can just
But
put the flow seal and surgery seal. Everything will be sealed immediately. Surgery flow seal, anything.
And that was the kidney that nobody wanted to take.
No, I'll tell you, it will be interesting to know, when we were training, this is 1980, the transplant was in infancy, there was no cyclosporine, prednisolone dose used to be 200 milligram. Okay, and a lot of complication, wound infection, ureteric complication rate was 25%. At that time, at the end of the procedure, it was routinely capsulotomy was done from one pole to upper pole. It was routine procedure because they feel that kidney is very edematous, and so by doing capsulotomy, edema will be relieved and kidney will function better. That was the concept, 1980.
So it's very interesting you say that. One of my partners, so we accepted a lot of kidneys that everyone would turn down. So we had a very high DGF rate. One of my partners would routinely, after the kidney is not working, they would go back on day 2 or 3 and do a capsulotomy. But I don't think that made any difference. If DGF, it'll resolve over a period of time, you just have to be patient. That capsulotomy did not expedite recovery from DGF in those patients. It still took its own sweet time. But yeah, that's a concept that a lot of people still do today.
But it stopped around 82, 83.
Yes.
The boss stopped doing it.
So coming to our next case. This is a right side donor nephrectomy being performed, and while placing the ports, so this was the liver retraction port being placed. So coming to the solid organ injuries, so how would you approach for managing such?
I use hand assisted. So I first put the gel port and all the ports are placed under the guidance of my hand. So you never have this. unless you lacerate your own finger.
Yeah, again, I will say this is not doing carefully. If you carefully do it, it will not happen because now you have already a telescope.
Yes,
so
sir.
what is happening? You are seeing, and the boy is putting under vision, and he is not experienced and just put too much of pressure and it comes out with force and hits the liver. Because you are just doing it. As soon as the tip is coming out, you just change the direction, it will go other side.
Yes.
So it is the
Prevention.
just what happens in training program, and that nobody is watching at that time, and that president has just done it.
So careful surgical technique, even like from the incision to closure.
So another case is also from a donor nephrectomy, in which there was a bleeding from Eval's lumbar vein. So either control was taken, and then again a clip was applied. So any tips for managing such kind of lumbar injuries?
So I really obsess about lumbars. I get reconstructions to make sure I know exactly how many lumbars are there, where they are, and then you just have to be really careful.
See, these are the one thing I have learned the trick, because number of times I'm called to stop that kind of bleeding. First thing is put the suction and don't suck it. Suction is done, kept over the gauze piece or over the surgical as a pressure. Because if you keep sucking the blood, you think there is no bleeding is happening, but that suction bottle will be filling up. So that is the first thing. Suction to be used as a pressure point and little bit of suction just to see over a gauze piece or surgical. So once that part is done, you might have to either put another port if you need to, or what I do from my right side, I'll put the suction. Left side, I'll bring the Maryland forcer. And very gently, I'll remove this pressure, and with the Maryland, I'll grab the IVC edge or lumbar vein edge or whatever. Now it is under my control. And so now on the right side, I'll bring the clip or whatever I want to do it, I'll bring a clip and apply it. And that is this maneuver, most of the time we have been able to do it. After putting the clip, if I'm not very happy that this clip is probably may fall off after some time, then now there is no bleeding. But at least the situation is under control. Then for vein I don't bother. I take 3-0 vicryl suture and just put a rescue stitch, and I'll run around it and then put another clip or tie it. But if it is the artery, then we use the 3-0 or 4-0 proline, put a rescue stitch, and then just go there and tie it. So that's how we have managed most of the smaller injuries, like avulsion of the smaller vessels, avulsion of the lumbar artery, avulsion of the lumbar vein. And most of the time we never have to open up, and we could have good control.
But do you normally know ahead of time, like from your scans, about the lumbars?
But surgery is done by so many people, and everybody is not so careful to going and looking at. Sometimes you ask him what is there, the resident is looking here and there. So they are coming in the morning and starting the procedure without even. This is something the culture has changed. And but that is really happening. Sometimes you ask, he's going to scrub, and the resident is not aware of, because he's just come and he has not seen the case. He just come in the morning. Patient was admitted in this is private hospital. Patient may be admitted 11 o'clock night or 6 o'clock in the morning. So when the patient come, only then he will see the file. So he is not aware of it. But as most of time I am aware of what is happening. So I tell them. So now what we have done, we have created a WhatsApp group. So beforehand all the information is pasted on that, so that everybody is aware, but still there are some who don't read it.
So in CTs too, like we get 1 slices so that you don't miss a small lumbar, especially you know in the section of the entire like the vascularity of the kidney. Everywhere else it's 3 but there we get 1 slices, and then we get them reconstructed, so we know exactly what we are dealing with in terms of vascularity. And so if you know ahead of time, you're going to be very careful.
And I have also noticed, and I keep telling all the residents, their habit of reading the reports. He said, read the report only after looking at the images. And they will not go like, if I see there is sometime I read the report again, and if I'm not happy, some of the time we went there and asked the radiologist that you are wrong to do the correction. Why it is looking like that? I don't know, but it is not looking like that. So then they look it better. Sometimes they have made the report correction. But what I'm trying to say that if you see something, you are not very happy, then you go there and sit with the radiologist. All the time they are available on the computer. There is the bigger image, and they run it sequence and they explain everything. And that's how at least I have learned most of the radiology. So, but somehow now they just read the report.
So we actually, I have a lot of interest in this, so I even do the reconstructions myself. So I have the software in my office where I can do it myself. So most of the times I'll not look at the report, I'll just look at the CT for a long time, make sure I know exactly everything that I need to know. And if I have any confusion, I go to the radiologist and read it with them. But
So
that's very important.
You should take the clue that looking everything in great detail before the operation and knowing everything is very important. That's what we do sometimes, extra investigation. Extra something before you finally go for operation. The reason is when you go for operation, you should prepare what you are going to see. But we are trying to imbibe this culture in young generation, but it's difficult to do that.
So even the length, a lot of times that they report, they'll report the length from the aorta, but I'll tell them that, you know, I want to look at the length from the my stapler, so there'll be at least 3 of loss there. So start looking from here and don't go all the way to the hilum. All the hilar bifurcations, I want to see to the first bifurcation. So that is the length that I'm interested in, and that is the length you need to know. And like every little detail is very important, especially in lab. We spent a lot of time looking at these.
So I think the message
Sometimes
is
the donor operation is going on, the film is not there. On the, when I come there, where is the film? So nobody bothered to look at it. So these are really happening. I'm not joking and exaggerating. And that's what I want, that we should change this culture.
So the message is the person who is operating, he must see the CT angiograms, because very, very carefully, maybe go to radiologist, sit down, run the entire CD, because films are sometimes, they will be giving you only certain cuts. But the important information may be there, which is lost in this, which is not there. And it depends on the reporting radiologist, whether he has put it there or not. So these things are important.
Like just take the today's example, the donor nephrectomy. We knew that there is a vein going like that, and we were not getting it where we were expecting it. But since we know that there is there, and it's a significant vein, so we were doing very careful dissection, and finally we could see it. And where I was expecting, I was not getting it.
Yes,
so this is only because I am aware, so I am very careful, and finally you get it.
Proceeding to our next case, a 26-year-old female who has underwent open kidney transplant in 2022. DJ stent was removed after 2 weeks, and the creatinine was stable at 0.7. She was on a regular follow-up, but after DJ stent removal, the creatinine was on the rising trend, and we have performed ultrasound. There was a mild graft hydronephrosis, and on graft biopsy there was mild ATN, and she had a UTI which she underwent treatment. So the creatinine now is 1.9 from 0.7, and DTPA was performed. So there was a preserved perfusion with cortical uptake and sluggish drainage. what could be the possible thing that comes to your mind, sir?
Was there any collection on the ultrasound?
No, sir, no collection, only just hydronephrosis.
And how was your ureteric anastomosis? How was the bladder?
Occult PUJ?
Was it a small bladder, fibrous detrusor, or was it a healthy bladder?
It was a healthy bladder, sir.
And ureter length was good?
Ureteric length was also good.
So it was too long?
Not like that, sir.
And I would think something like, your anastomosis probably immediately after, if it's happening immediately after the stent removal, which is usually on 10th day, you said?
12th day.
Yeah, that's probably what you would consider.
So
occult PUJ obstruction?
This was the CT image.
Mild hydro, moderate hydro. So do you do cystograms in these to look for any stenosis or no?
Straightforward, we'll do the percutaneous nephrostomy and do the antegrade nephrostomy.
So nephrostomy tube was placed and a nephrostogram was performed on table. So the contrast was going into the bladder, but there was a slight narrowing at the anastomotic site.
I think it's the vascularity problem. It's a living donor?
Yes, sir.
Right? Because this would happen only if the vascularity at the lower end was compromised. That's why you'll have this stenosis immediately after taking this out. So was there good bleeding from the ureter edge when you were transplanting it?
Yes, so the ureter was healthy. It was bleeding also.
We make sure, but that cut end of the ureter is bleeding, and more often we have to stop the top bleeding. Little bit bleeding, we stop it with a very fine touch of the diathermy. And but there's two things. While putting the suture, the most important suture is at the angle. If you have taken a little more suture, there will be stenosis, even if you have spatulated that much. So sometimes there is a technical problem, and that's what we keep teaching. You have to be very careful about every stitch. But nowadays, what happens is when the artery vein is done, you de-scrub, go for other case, and then leave it to the resident to do it. So we don't know what happened, but it happened. Otherwise, it should have not happened. So.
We usually see these in deceased donor transplants, where the bladder would be very small, very fibrous, ureter was completely stripped. Even you cut it down to a very short length, but if the vascularity is bad, then you're going to have the anastomotic stenosis. We don't worry about the technical aspect as much because it's always done by an attending, and you really are confident about your anastomosis. So that is the last thing that comes to our mind, that it is a technical fault, because unless if it's a technical thing, you would know, you didn't do it right, so you're going to expect things. But most of the times that's not the case. So even when in artery, if my radiologist will send a report where the velocity is 200 and they'll report it as transplant renal artery stenosis. And I know it's a aortic patch, it's a Carroll patch, it's a 1 centimeter long anastomosis. There is no way this is going to stenose in my lifetime. So I just discount those. But here it's probably technical. It was technical then?
I don't know what was there. So what was done?
So
I don't remember which patient.
Balloon dilatation.
Antegrade balloon dilatation followed by placing a DJ stent for 4 weeks. After that, the creatinine started coming down, and following DJ stent removal also the patient is fine and the creatinine is stable.
And the stenosis was at the anastomosis?
Yes,
or just
at the
proximal?
anastomotic
At
site.
the anastomosis, right? So how long after is it safe to dilate that anastomosis? So this was apparent 12 days after you removed the stent, right?
After that, after 12 days, the stent was removed, and after 10 days, the PCN was placed because the creatinine was rising.
But all these things that we do it, this balloon dilatation, antegrade stenting, everything.
Yeah, that's the advantage of urologists doing a kidney transplant. We depend upon IR for all this.
So such situations are actually salvageable by endourological management, like balloon dilatation, in most of the cases. But then, of course, 20-25% chances that it may re-stenose, and then you should straight away go and do a surgical correction.
Yeah, so that's what I was going to say next. So if it is so close to the surgery and you know it's technical, I think the best long-term solution is to go in and redo it. Rather than keep stenting, you'll keep having UTIs in the long term. This balloon dilatation will work for a few months, then you'll need to do it again. So it's better to do a surgical if it's very close to transplant.
But one attempt can be given. That's what we
have patients referred by others, and there is a ureteric. We have patient, after one patient we had, a transplant was in 2019, and he came back now with the ureteric restriction 6 years later, and there is BK virus negative. And so in that patient, and nowadays what we do, we go with the robot, and if we get the dilated pelvis very clearly, then we do ureteroplasty. Otherwise, some of the time it is so much of fibrosis, so we straightway go drop the bladder and go at the bladder and where we believe that ureter was transplanted, and we get the adhesions. We know the here is ureter, so we cut it. And once we cut it, we know that we get the ureter, and then we just mobilize it, and then just do the. Sometimes we have done the reimplantation, and sometimes we could bring the ureter. So with the robot, it's quite easy. Yeah, I think we can stop it here.
Thank you, sir.
2 o'clock.
Thank you very much.
And I would like to announce the prize for the video and poster presentation. That video presentation first prize is Dr. Umar Khan for his robotic living donor nephrectomy in a patient with horseshoe kidney. So he will get a prize of 5,000 rupees. Second prize goes to Swapnil Kushwaha. He will get 3,000 rupees for extraperitoneal robotic assisted kidney transplantation. Third prize goes to Saunak Mitra, 2,000 rupees. Innovative technique of reducing rebound ischemia time. And the poster presentation, first prize goes to Saunak Mitra, 5,000 rupees for living donor renal transplant after ex vivo partial nephrectomy. Dr. Devi Chauhan will get 3,000 rupees for second prize, orthotopic renal transplantation. And number 3, Navneet will get rupees 3,000 for rare case of graft renal artery aneurysm. So with that, we'll do the valedictory function. I would like to thank again for all the delegates and Dr. Rajiv Sharma and Dr. Tanege. I think he has left. He's gone to some other hospital. He give lecture. Apollo Hospital. So, and all the delegates, because without delegates nothing was possible. And I also like to thank all my residents. They did tremendous job. All my secretaries, special mention to Ayush, who I think 80% work was done by Ayush, and if you would have not done, we would have collapsed. And this time I didn't do anything except asking what is done, what is not done. So at least I am quite happy that I had relaxed time and everybody is taking up. And also like to thank all the staff of the Max Hospital, anesthetists and technicians, nurses, everybody for coming on Sunday and helping us to, because Sunday we choose to do the donor recipient both robotic because robots were not being used. It was free today. So otherwise it was very difficult to get the robot. And so with that, this session is open. If anybody wants to say something or comment or give us some advice to improve further our meeting, you are most welcome.
So it was an excellent operative presentation of all the cases. You made these things look so simple despite all the learning curve and other things. Your team is awesome. All of them did a wonderful job. Dr. Samit, Dr. Pragnesh, Dr. Ruchir, all of you did a tremendous job in the OR. It's really nice to watch you and your team again after 1 year do incredible operative procedures. It's just, you know, you're pioneers in this, especially extraperitoneal. No one is doing it. It's awesome.
If anybody wants to say anything, otherwise we should come here and have a group photograph before we go for the lunch.
अरे वो लैपटॉप कहाँ गया?